Recitation, survival from the cardiac arrest remains low, especially in the developing countries like India. Now, the emphasis shifting from just a return of pulse to the return of meaningful life. That's why AHI is included recovery part to the survival chain. And in this presentation, I am covering the gaps existing in the implementation of current cardiac arrest guidelines and some emerging innovation that could help us to enhance our recitation outcome. So, while we are dealing with a recitation, it will not be completed by knowing the underlying physiology. When we are coming to the physiology, there are three phases of cardiac arrest. First phase is electrical phase, followed by circulatory phase, then metabolic phase. Electrical phase is from 0 to 4 minutes. Circulatory phase is 4 minutes to 10 minutes, and after that, after 10 minutes, it's metabolic phase. And each phase have its own relevance. When coming to the electrical phase, here the myocardium is still viable during this phase because ATP stores are still present within the myocardium. So here the importance goes for the defibrillation. Defibrillation is extremely effective during this first few minutes of arrhythmia. We can see some of the studies. So if we defibrillate within the first 30 seconds, it's showing a 98% of success rate. But if there is a delay of 3 minutes, then success rate is reduced to 70%. And if there is delay of 10 to 15 minutes, then success rate again reduces to 20 to 30%. And survival chances reduces by 7 to 10% per minute in a non-CPR patient and 3 to 4% per minute in a patient with ongoing CPR. So it is clearly evident that as the time lapses, the survival chance also reduces. So during this electrical phase, the priority is for the defibrillation. When we are coming to the circulatory phase, here what happening is the ATP stores get depleted. So if VF is caused in the electrical phase, it will become gradually to fine VF and later ultimately into asystole. So here the more importance is for the perfusion. So we will prioritize chest compression and epinephrine during this period. And if we have a doubt about the rhythm, whether it's a fine VF or asystole, we should take it as a asystole and emphasize on chest compression. Previously, actually, we were considering it as a fine VF and we were shocking. Now, but the problem is if it will be perfusion will be compromised. So, during the circulatory phase of cardiac arrest, chest compression and epinephrine have priority. When we are coming to the metabolic phase, if we are starting the CPR during the metabolic phase, the survival chance is very low and it is characterized by extensive cerebral cell death and impending myocardial necrosis. So the effective compression will cause the reperfusion damage. So if we are starting the chest compression during this metabolic phase, the outcome is very poor but not zero. So even in metabolic phase, we can consider the chest compression. This is the tabular format of these three phases: electrical phase, circulatory phase, metabolic phase, and what is happening in the myocardium and also where we should prioritize. Now we can see some of the data from the literature regarding the survival to hospital discharge. In outside hospital cardiac arrest, for shockable rhythm, the survival chance is 25 to 35% in developed countries, while 5 to 20% in developing countries, and in less than 10% in Indian studies. For non-shockable rhythm, it is 1 to 6% for developed countries and less than 1% in developing countries. For inside hospital cardiac arrest, for shockable rhythm, it is 30 to 45% for developed countries and 10 to 20% for non-shockable rhythm. While we are dealing with the developing countries, it is according to the hospital standard, because since it is a inside hospital cardiac arrest, if the hospital standard is very good, the data will be comparable to that of developed countries. So while seeing these two, it is very evident that the developing countries are very much lacking behind in the survival rate. And here is the importance of gap existing in the implementation of current cardiac arrest recitation guidelines. And we can see what are the gaps present. So the area will be like pre-hospital chain, quality of CPR, team dynamics, post-ROS care, technology, research and ethics. And the unaddressed gaps in each area: pre-hospital chain, it is low bystander CPR and AID use. In quality of CPR, inconsistent compression quality. In team dynamics, it's poor leadership and unclear roles. In post-ROS care, it's the neglect of neuroprotection and hemodynamics. In technology, underuse of feedback devices, ultrasound. And research, always, most of the data is coming from the developed countries. Very limited data is coming from the low and middle income countries. So always the guidelines are skewed towards the developed countries. In terms of ethics, there is poor communication about the futility and the end of life. So we can see each one of these. When we are coming to the pre-hospital chain, the main gaps existing are very low bystander CPR rate, poor EMS response time and poorly equipped EMS, delays in transport and delays in definitive care, lack of good cardiac arrest registries. In developing countries, these pre-hospital chain gaps will contribute maximum reduction in the survival rate. When we are coming to the quality of CPR, everyone knows the components of high quality CPR: adequate rate, adequate depth, allow complete chest recoil, minimize interruptions, and avoid excessive ventilation. So what are the importance of these components? Is nothing but the underlying physiology. So we are actually targeting to maintain a coronary perfusion pressure of 15 mmHg. And coronary perfusion pressure is equal to aortic diastolic pressure minus right atrial pressure. All these components of high quality CPR, we are targeting to maintain a optimal coronary perfusion pressure. And if we have interrupted in compression, it takes about 15 seconds of compression to build the CPP again. So there will be a delay, and obviously it will reflect in the outcome as well. One thing we have to emphasize is chest compression fraction. It is the total percentage of time we utilized for the chest compression out of total time we used for the code. And CCF is a strong predictor of survival and neurological recovery after cardiac arrest. Studies show higher survival rate if the CCF is greater than or equal to 80%. And now according to AHA guidelines, we have to target a CCF of ideally greater than or equal to 80% and at least greater than or equal to 60%. We can calculate CCF by CPR feedback devices or manual timing. What are the ways to increase CCF? One is pre-charge the defibrillator. So 15 seconds prior to the analyzing rhythm, we can pre-charge the defibrillator, and soon after, if the rhythm is a shockable rhythm, we can give the shock and resume compression. So like that we can minimize the interruptions. Second technique is compressor should hover over the chest. Hovers technique means the compressor is just taking the hands away from the chest, but it keep above the chest only. So soon after giving the shock, they can continue the compression. Then intubate without pausing compressions. And one more technique is consider CPR protocols that deliver fewer pauses. Example, continuous compression with asynchronous ventilation using bag and mask. So our aim is to increase the quality of CPR. There are some physiological feedback devices we can utilize for this purpose. And one of the example is capnography. The purpose of capnography in cardiac arrest resuscitation is, one is to confirm the correct airway placement, to monitor quality of chest compressions, to detect ROSC early, and to guide the resuscitation efforts or termination. And we can interpret as if the ETCO2 is greater than 20 mmHg, it means a good quality of chest compression. If it is less than 10 mmHg, it means inadequate compression, so we have to improve the quality of compression. If there is a sudden rise to 35 to 45 mmHg, likely ROSC, and zero or flat line waveform, it means dislodged or misplaced tube. And capnography, we can also use it for the prognostic purpose. So if the ETCO2 after 20 minutes of resuscitation, if it is less than 20 mmHg, then it means a higher chance of ROSC, so we have to continue the resuscitation. If it is less than 10 mmHg, almost no chance of ROSC, so we can terminate the resuscitation. Like capnography, another thing is arterial diastolic pressure. We already told about the coronary perfusion pressure, that is equal to aortic diastolic pressure minus right atrial pressure. Here is the importance of diastolic pressure. And our diastolic pressure targets are in adult shockable rhythm greater than or equal to 25 mmHg, in adult non-shockable rhythm greater than or equal to 20 mmHg, for infant cardiac arrest greater than or equal to 25 mmHg, and pediatric cardiac arrest greater than or equal to 30 mmHg. So if we are driving a recitation according to the diastolic pressure, it will be like if the diastolic blood pressure is less than 20 mmHg, despite good compression, it means inadequate coronary perfusion. So we have to give epinephrine early and repeat sooner. If the diastolic pressure rises greater than or equal to 25 mmHg after epinephrine, it means good vasoconstrictor response. So we can delay the next dose until DBP drops again. When DBP remain low despite multiple doses, it means poor vascular tone or mechanical problem. So we can improve chest compression quality or mechanical support. So here we are guiding the recitation according to the diastolic blood pressure. That is a physiologically directed recitation. Studies are showing that have good outcome. When we are coming to the team dynamics, an effective team dynamics ensure coordinated, uninterrupted and high quality recitation, directly improving survival in cardiac arrest. Studies show high functioning teams improve survival in both outside hospital cardiac arrest and inside hospital cardiac arrest. So everyone knows about the importance of high performance teams and the roles of each persons and how we should communicate. But when it is coming to a real scenario, the role allocation is poor and everyone's performance is poor, and at last everything will mess up and it will result in poor outcome. According to the 2020 AHA guidelines, there is a new role as CPR coach. This is not an extra person. Usually it is blended into current responsibility of monitor or defibrillator. CPR coach support performance of high quality BLS skills, allowing the team leader to focus on other aspects of clinical care. So the role of CPR coach is nothing but make sure a high quality CPR. When we are coming to the post-ROS care, it focuses on reducing neurological sequelae and organ dysfunction while identifying and addressing the reversible causes of cardiac arrest. In 2025 AHA guidelines, cardiac arrest survivors and their caregivers should undergo structured assessment and treatment for emotional distress after medical stabilization and before hospital discharge. So, according to new guidelines, we are also including the caregivers and giving the emotional support. So, according to 2025 AHA updates, we can see what are the changes in the post-ROS care. One thing is we have to target a optimum saturation of 90 to 98%. Previously, it was 92 to 98%. And there is an emphasis on targeting a map of at least 65 mmHg, and also it is recommended to do a CT of head, thorax, abdomen and pelvis after the ROS. It will help to identify the contributing factors for the cardiac arrest, also the injuries that happen during the recitation. And also point of care ultrasound and the echocardiography after the ROS also recommended. Another important area is temperature control after the ROS. Previously, we were considering a hypothermic targeted temperature management of 32 to 36 degrees Celsius. But over the years, many studies have happened like TTM trial, TTM2 trial, capital chill trial and hyperion trial. All these studies are showing there is no specific advantage of hypothermia over normothermia. So our current guideline is to maintain a hypothermic to normothermic fever prevention temperature control. Basically, we can consider hypothermia also, normothermia also, but main target is fever prevention. So we told about the technology. Always our developing countries are very much lacking behind using the new technologies for recitation. One is feedback devices. These are the tools that monitor and provide real-time feedback on the quality of chest compression and ventilation during CPR. And the aim of using this is nothing but make sure a high-quality CPR. It will give the feedback so we can rectify it and make sure it's happening. And there are many types of feedback devices that working according to different principles. These are some of the examples. This Zoll Real CPR Help is a audio feedback device, while CPR meter is a audio visual feedback device. So the technological part, when we are coming, there is another we are lacking behind is mechanical CPR devices. There are two types of mechanical CPR devices. One is pneumatic piston device and load distributing band devices. Michigan and Lucas are example of pneumatic piston device. Zoll Autopulse is an example of load distributing band device. The advantage of mechanical CPR device is Allow chest compression to be performed with consistent quality. Defibrillation can be safely performed during compressions. Decreased interruption to compression. Allow safe performance of chest compression during retrieval and in confined spaces like ambulance. Allow cognitive offloading and frees up some personnel. Can facilitate PCA and ECMO during PCA. These are the examples. So according to AHA, it is not recommended routinely, but we can use in some circumstances like requiring of prolonged CPR, and also if the intervention is going on like PCI and ECMO. Then I will tell some modifications in the CPR. I am telling about 3 modifications. One is IAC CPR, ACD CPR, and 4-phase life stick CPR. All these 3 modifications are underlying working principle is same. We are increasing the venous return to heart, and that's why we are increasing the cardiac output. This IAC CPR is interposed abdominal compression CPR. It's a modified form of conventional CPR where abdominal compressions are applied between each chest compressions. And a firm pressure is applied but not excessive, just to increase the intra-abdominal pressure and augment the venous return. But problem is it's required trained rescuers, and it is contraindicated in pregnancy, severe obesity and abdominal trauma. This is the IAC CPR. One person will be giving the chest compression followed by abdominal compression. This will repeat. And next is ACD CPR, active compression decompression CPR. Here also mechanism is same, but we are using a suction device over the chest, and during the decompression it will make a negative pressure and increases the venous return. A 4-phase life stick CPR, it is the combination of earlier 2. Here we are using compression decompression of both chest and abdomen. This is the device used for that. So we know all these 3 modifications, obviously it will increase the venous return, it will increase the cardiac output, and hence the ROSC also, survival chance also increases. But the problem is it needs special devices and expertise. One main problem during resuscitation is refractory shock. In our professional life, many times we are coming across this refractory shock. There is no ROSC even after multiple attempts of defibrillation and drugs. So some new strategies are coined called double sequential external defibrillation and vector change defibrillation. In double sequential external defibrillation, what is happening is here we are providing 2 defibrillations. One is conventional technique in the anterolateral direction, and one more pad is attached in the anteroposterior direction. And defibrillation is delivered one after the another. In vector change defibrillation, what is happening? If it is a refractory shock, then we are changing the pad position from the conventional anterolateral position to anteroposterior position, and subsequent shocks are delivered in this direction. And studies like DOSE VF trial are showing higher survival chance if we are using these new strategies in the resuscitation. That's why AHA also included this double sequential defibrillation in the new guidelines, not as a routine therapy, it's as a rescue therapy. When we are coming to the traumatic cardiac arrest, the main thing we have, how it is different from the medical cardiac arrest. One thing, we have to deprioritize chest compression, deprioritize epinephrine, and we have to prioritize addressing the reversible cause of cardiac arrest. In traumatic cardiac arrest, we know the most common cause of cardiac arrest are hypoxemia, hypovolemia, tension pneumothorax, and tamponade. Out of this, hypoxemia should be treated as medical cardiac arrest only, but remaining 3, the approach is different. In a chest compression in a traumatic cardiac arrest, CPR should be de-emphasized with emphasis on correcting the reversible cause of cardiac arrest. Reason, compressions cause delay to potentially life-saving treatment, and compression may displace clot or worsen the injuries like chest wall injury and pulmonary injury. So in a traumatic cardiac arrest, focus on treating the cause first. Only after this intervention, if there is no pulse, chest compressions are appropriate. Like that, epinephrine also. We know why we are giving epinephrine in a traumatic cardiac arrest, to cause vasoconstriction. But in a traumatic cardiac arrest, there is a massive catecholamine release causing widespread vasoconstriction. So in hypovolemic or obstructive traumatic cardiac arrest, there is no obvious physiological benefit to epinephrine, may actually worsen the hemodynamics. But in hypoxic traumatic cardiac arrest, epinephrine may be reasonable. if oxygenation is addressed. And all the new guidelines are deprioritizing the chest compression, deprioritizing the epinephrine, use of epinephrine. So the main difference is in medical cardiac arrest, we are targeting to get a optimal chest compression fraction, prioritizing chest compression. But here we are prioritizing to address the reversible causes first. So we know in October 22nd only AHA new updates has come. We can see some of the major changes. In major theme only it's changed like personalized physiology directed resuscitation using ETCO2 and diastolic blood pressure, and integration of technology like AI, real-time CPR feedback devices, mechanical CPR devices and all. In BLS, they included the chest compression fraction of greater than 80% to be aimed. And in ACLS, included double sequential defibrillation. In post-ROS care, the temperature target is changed to 32 to 37.5 degrees Celsius. And the key point is monitor physiology, not just the rhythm. So the resuscitation should be physiologically directed resuscitation rather than time directed or mechanical target directed. And other updates are previously in a infant cardiac arrest, if a single rescuer is there, we were giving 2-finger technique for the chest compression, but it is replaced by 1 heel technique. And other foreign body obstruction, previously for infants we were using 5 back blows followed by 5 chest thrust. For adult we were using Heimlich manner, that is abdominal thrust. But now it is replaced as 5 back blows followed by 5 abdominal thrust, both for adult and children. For infants it is same. And one more change happened in the adult tachycardia algorithm. Previously monomorphic VT was treated, if it is a stable it was treated with procainamide, amiodarone and sotalol. Now sotalol is excluded from the list. And when we are coming to the electrical cardioversion, in the case of unstable tachyarrhythmia, the dose of synchronized cardioversion has changed. For atrial fibrillation it is 200 joule, for atrial flutter it is 200 joule, narrow complex tachycardia, that is SVT, it is 100 joule, for monomorphic VT it is 100 joule, and polymorphic VT it is not synchronized cardioversion, it is defibrillation. Thank you.
Thank you, Dr. Hafiz. Over to our chairpersons for any remarks or additions.
Both the emergency as well as the critical care department by SHIFA
Thank you, sir. Thank you, ma'am. Any questions from the audience? If not, we will proceed to our next session.
Thank you, Dr. Hafiz, for that insightful and thought-provoking session, reminding us that even familiar protocols can still offer new lessons.
I now request Dr. Femita to kindly present mementos to our speaker and chairpersons as a token of gratitude. Dr. Hafiz PM, please come to the stage. Dr. Aishwarya N and Dr. S. Ramdas, please. Continuing the academic flow, now we turn to a topic that reminds us how quickly a joyful moment can turn critical: peripartum cardiomyopathy, newer developments and practical management. The session will be handled by Dr. Jidesh Gangadharan, HOD and Consultant Intensivist, Department of Critical Care Medicine, EMS Memorial Cooperative Hospital and Research Center. I warmly welcome our chairpersons for this session: Dr. Said Nawaz Afzal, Interventional Cardiologist, KIMS Al-Shifa, and Dr. Aditya Balagopal, Consultant Gynecologist, Pentalmana Nursing Home, to kindly come forward and take their seats. Over to you, Dr. Jidesh.
It's not coming. Please do scan this and please do. It's some pre-test. Actually, I would love if you guys do this. It's around 10 MCQs. Just go through that, submit it, and we'll see how it turns out. And thank you, Prem sir, for inviting me to such a beautiful program. Nandakumar sir, scan the. Are we done with it? Can I start? How many are submitted? Few more are there. Two more. We'll give two more minutes. Yeah, so now there is almost 14 responses. Good. So, so, so actually the topic given to me is like peripartum cardiomyopathy, newer developments and practical management. I tried to start preparing the slides with just the management part. Then I was feeling I was not doing justice to the topic. So I'll go through the some definitions and all, then I'll rush those slides, then I'll go to the proper management. So the first case definition for peripartum cardiomyopathy came in the year of 2000. That was done by National Heart and Lung and Blood Institute and Institute of Rare Disease in the year of 2000. Actually, it was more of a restrictive definition. It was focusing on 4 major points. That one is heart failure that is developing in the last month of pregnancy up to 5 months of puerperium. So the definition itself is like peripartum cardiomyopathy, and there should not be any identifiable cause of heart failure, no structural heart disease, and echocardiographically they have defined the how heart should be. Like ejection fraction should be less than 45, fractional shortening of less than 30% should be there, and heart should be dilated by LV and end diastolic volume of more than 2.7 centimeters square. Then next definition came in the year of 2019 by the European Society, and actually this is more of a inclusive one. Actually what they did, they abolished the time frame. Like any heart failure that is developing towards the end of pregnancy and in the postpartum period, they will take it as peripartum cardiomyopathy. So this is one important thing. Earlier the time frame was very specifically defined, last month of pregnancy and 5 months of puerperium. That got changed. Absence of any other identifiable cause, it's same. Then the other one is like LV, systolic dysfunction, where ejection fraction is less than 45. This remains same, but here the heart can be either structurally normal or it can be dilated. So that part also they have changed it. So this is what happened from restrictive to inclusive. So actually I had described all those things like initially it was in the last 5 months. Now there is no limit, and one is like any size of heart, LV may be dilated or not. So what is the epidemiology? Epidemiology, the global incidence is like 1 in 2000, and the higher incidence happen in Nigeria, and in India the incidence is like 1 in 1,300 cases, while in developed countries like US and all, it is like 1 in 4,000. So what all are the risk factors? Risk factors for peripartum cardiomyopathy has been divided like proposed, probable and emerging risk factors. Like proposed risk factors are like smoking, hypertension, malnutrition, cocaine abuse, African ancestry, and The probable risk factors are like twin pregnancy, high parity, high gravida, and extremes of reproductive age. And now the emerging ones are preeclampsia, obesity. Now, this is one most important slide actually, the pathogenesis of peripartum cardiomyopathy. So I will start going from the least important one to the most important one. So first one, that is the impact of viruses. The exact impact of viruses in the pathogenesis of peripartum cardiomyopathy is not yet known, but there are studies that has been suggesting viruses do play some role, especially the cardiotropic viruses are playing some roles. The second one is like hemodynamic changes. Actually, what happened towards the second and third trimester, hemodynamic changes do happen. There happens a volume overload, there happens anemia, which increases the cardiac stress, thereby increasing the cardiac workload and thereby leading to a heart failure. Then the other one is like during the pregnancy, the placenta will produce SFLT1, which is an anti-angiogenic factor, which will act on the, which inhibit VEGF, thereby leading to inhibiting the cardiovasculature and thereby leading to the development of heart failure. The other one is like it will produce STAT3, which is responsible, which is an enzyme that inhibit superoxide dismutase, thereby increasing the occurrence of reactive oxygen species and free radicals, which will increase cathepsin D, and also that act on directly on cardiac vasculature and thereby leading to malfunctioning of the cardiac myocyte. Then the most important one, like the prolactin. The prolactin plays the key role in the pathogenesis actually. Prolactin usually helps in relaxing the muscles. It is produced from the pituitary, and what happens is prolactin is acted on by cathepsin D, and it produces a molecule that is 16 kilodalton prolactin, and which is the responsible for the pathogenesis. It leads to it inhibits cardiac vasculature and also act on cardiac myocytes and thereby leading to the endocytosis. This microRNA 146A, that happens because of the 16 kilodalton prolactin that has direct effect on the cardiac myocytes. Now, these all are the signs and symptoms of peripartum cardiomyopathy. I don't want to focus on this slide because, see, the signs and symptoms of peripartum cardiomyopathy will be similar like that of a typical heart failure. Patient will be breathless, orthopnea, PND. And actually in clinical signs, actually I want to tell something about hepatojugular reflex actually. See what happens, most of the pregnant females will be breathless because of due to the gravid uterus. As well as anemia may be there. So their complaints of both breathlessness will be there, and they will have edema also because of the gravid uterus compressing the vena cava and thereby leading to the edema. So one thing is like if they change the position, the edema because of due to the gravid uterus usually disappears. And if we do a hepatojugular reflex, what will happen? Usually with every second or third beat, the elevated JVP will usually get disappears. But if there is an impending heart failure, the elevated JVP won't disappear. So you can see that you are not dealing with some breathlessness of pregnancy, you are dealing with something other. And I always also want to insist, like remember, ask about specifically if a patient complains of orthopnea, of breathlessness, I want you to ask about orthopnea, PND and palpitation. Now, see, I had already discussed this one, like in a normal pregnancy, all these three will happen. And so, specifically look for JVP, look for other signs like PND, orthopnea and palpitation, look for these things. That is one thing we can do. Then like in what happens with the preeclampsia. Preeclampsia will also lead to diastolic heart failure. That can also impact this thing, along with there will be proteinuria and all will be there. So that can also interfere with our this thing. So how will we work up for this case? So workup is usually like any other case of heart failure. One thing what we want to do, we want to rule out a structural heart disease. So basically we want to rule out a rheumatic heart disease or any other heart disease that is happening. So basically other workup we will send is like we will go for natriuretic peptides, ECG, chest X-ray and echocardiography. So in natriuretic peptides, the BNP we have kept a cutoff of 100, and for NT-proBNP it is more than 300, and echo should be echo heart should be structurally normal, MR may be there, TR may be there, ejection fraction is reduced, and the heart can be either dilated or it may be normal. So this same slide again. So what all are the differential diagnoses that we can consider at this particular for this disease? So usually it will be a pregnant female coming to us with breathlessness towards the term. So one thing is like peripartum cardiomyopathy that I had already told. The next one is myocarditis. So if we take the history properly, there will be a history of either viral infection usually will be there, fever may be there, and if you do a specifically echocardiography, that again it will be a dilated cardiomyopathy, ejection fraction will be low. But if you do cardiac MRI, there will be an LE pattern will be present. Then next one is like pulmonary embolism. Pulmonary embolism, usually the thing will be, they will have a swelling of legs may be present, pleuritic chest pain may be present, and if we do echocardiography, RA-RV may be dilated, presence of a tricuspid regurgitation can be there. Then HIV-associated cardiomyopathy, that usually manifests towards the second trimester, and in case of a already pre-existing heart condition, usually it worsens towards the second trimester. Now, this is like, this slide is important actually. If you want to take photo, this is very important because this will define how will you treat the patient, like where the patient will stay, whether the patient you can manage it in the ward, you will manage it in an HDU, or you will manage it in an ICU. It depends on purely based on this single slide. So basically what they are doing, this is from the European Society. So what they have done, they have classified the heart failure into subacute heart failure, acute heart failure, and patient coming in cardiogenic shock. So ECG is like, other than tachycardia, nothing much of difference will be there. In chest X-ray, the thing is like, there will be some amount of congestion in mild case, moderate case, it will increase a bit, and in case of severe case, there will be full-blown, we will get a typical bat wing and all these things, and pleural effusion may be there. Then natriuretic peptides keep on increasing, like from the mild case, it will be less elevated, but they have not given any specific level, like this level means mild, this level means moderate, that is not yet defined. Then next one is echocardiography, like ejection fraction will be low in the, like 30 to 45 in a mild case, moderate will be 20 to 30, and in severe case, there will be less than 25. And if we do, the shock may be present, then full-blown presence of heart failure may be there, and RV dysfunction will be there. So then goals of managing a peripartum cardiomyopathy. See, the goals is again like typical, like how you manage heart failure. So there should be a treatment which is directed towards the heart failure. Then you should give a hemodynamic support. Then you should know how to plan intrapartum and delivery and long-term management. These all are the steps that you should think of when you get a case of peripartum cardiomyopathy. So basically, first one is the heart failure directed management. So basically, it go for decongesting the patient and relieving the afterload, or relieving the afterload as well as optimizing the preload. And then hemodynamic support, basically it goes for like stabilizing the heart, like if the patient is in shock, support it. If the patient develop arrhythmias, settle it. Then intrapartum and delivery, see, this actually requires a multidisciplinary approach. So whenever a peripartum cardiomyopathy comes, it either comes to a gynae person, or it comes to a medicine person or a cardiologist. So, but it usually needs a multidisciplinary approach. So actually it has to be planned properly how to deal with the case. Then like once the delivery and all are done, the next important stage is like, see, like other pregnancy related complication, it won't settle just with the delivery of the child. So this is most important. This patient will be on your long-term follow-up. You want to titrate down the drugs like any other typical heart failure medication, heart failure case. So you should always be planned with the long-term also when you get such a patient. So this is about the acute management. In the acute management, actually I had shown one slide. It's again, first step is classify the patient, whether it's a mild case, moderate case, or severe case. Then management literally goes parallel like a case of heart failure with reduced ejection fraction. But the problem comes in case of if the pregnancy is there, some drugs are getting contraindicated. So we will have some limitations over there. And we should have some consideration in managing the arrhythmias, anticoagulation, mechanical supports. So this is again that continuation of that slide that I showed earlier. So here, like in a mild case, the only thing what we can do is like we need to give oral heart failure drugs, oral diuretics, and give bromocriptine for a week. I'll go to bromocriptine. So there is a separate slide on bromocriptine. Then next one is in case of a moderate case, like it can be managed in a HDU. You give diuretics IV, vasorelaxant, give oxygen, avoid give inotropes if required. And what happens here, the bromocriptine dose increase from 1 week to 8 weeks, and other oral heart failure drugs. Then in case of a severe case, it should be managed in an ICU. Diuretic should be there, inotrope should be there. Inotropes needed based on the condition of the patient. Mechanical support may be needed. Type of support depends upon the patient's status. And bromocriptine again goes up to 8 weeks. And other oral heart failure medication. So this is about the oral heart failure medication. I'm not going to the dose and all. Certain things I want to say is like diuretics we used to give the decongest the heart. Beta blockers will try to basically control the heart rate along with protecting from the arrhythmias, and also it is one of the pillar in managing the heart failure. Then vasodilators, like usually the vasodilator we can use ACE or ARB, but in this particular stage it is contraindicated before the delivery of the child. So we will go for hydralazine and isosorbate. Digoxin is relatively safe. Inotropes like dobutamine and dopamine are safe. See, the other drugs which we usually use like ACE inhibitors, ARNI, SGLT2 and mineralocorticoid receptor drugs are actually contraindicated before the delivery of the child. So this slide is about the bromocriptine. Actually, I had already explained how bromocriptine acts. See, bromocriptine plays a single role, plays one of the most important role in the pathogenesis. The prolactin plays one of the most important role in the pathogenesis. Like it leads to the, it affects, it has anti-angiogenic activity as well as it affects on the cardiac cells. So basically, the bromocriptine is an antagonist of that, and thereby it prevents the generation of 16 kilodalton prolactin fragment and decreases the oxidative as well as the myocardial dysfunction. So what all are the evidences in favor of bromocriptine? So I will start with, I'll go from a single center RCT. So the first single center RCT that came in the year of 2010. So what they found out again in case of a peripartum cardiomyopathy, there is beneficial role. Then the next one came in the year of 2017, it was a multi-centric RCT. Again, they found out if you give bromocriptine, there is an improvement in the ejection fraction. Then these all are the two studies that got published in the year of 2025. The one that first right-hand side is published in the European Heart Journal. They found out that the woman who received bromocriptine for 6 months was associated with better maternal outcomes, and the other one is a meta-analysis that got published in the International Journal of Cardiology in the year of 2025. They found out that bromocriptine is associated with greater improvement in left ventricular ejection fraction compared to just standard cardiac treatment only. So about the dosage. So the dosage is like in case of mild peripartum cardiomyopathy, the dose is like 2.5 milligram once daily for 7 days. In case of severe with cardiogenic shock, it is like 2.5 mg twice daily for 2 weeks, then once daily for 6 weeks. Total, it becomes 8 weeks. And in patient on ECMO, actually, if you connect a patient on ECMO, the prolactin levels goes up, and actually what they found out that the prolactin level can again worsen the heart status. So in that stage, what we do, you increase the dose of bromocriptine, that is 10 mg twice daily, because at that stage we need stronger suppression of the prolactin. Now, next is antithrombotic therapy in peripartum cardiomyopathy. So what all are the specific conditions? 1A indication to use antithrombotic medication. So one is if already the heart is dilated, ejection fraction is low. As per the Virchow triad, there is a very high chance for forming a thrombus in the heart. So if you visualize a thrombus in the heart, definitely anticoagulate the patient. Patient is having atrial fibrillation because see this dilated cardiomyopathy again itself is a risk factor. So again you can anticoagulate the patient. Then if you are using bromocriptine, because bromocriptine is associated with higher risk for MI, stroke and venous thromboembolism. So definitely if you are using bromocriptine, definitely give anticoagulation. So and low molecular weight heparin is the preferred drug, and avoid and if you all know the warfarin should be avoided in the first trimester, then you can use it later, and towards the term start again using low molecular weight heparin. Next one is like occurrence of cardiogenic shock. So what will we do if cardiogenic shock develops? See, you go for norepinephrine, that is the one we are most comfortable with. Then we can also use milrinone or levosimendan. And the other thing is like you can use mechanical support like IABP, VA ECMO or LVAD. And see, this is the slide this is what I was telling earlier. what we found out that if we start using on VA ECMO, the reason is exactly not yet defined, but what they found out, if we use VA ECMO, prolactin levels are going up. So that is one specific state we give a bromocriptine at a higher dose, 10 mg BD. So then this one is like the outcome of so what they found out, like once you use mechanical support devices, what they found out that if you are using in a severe case, if you are using mechanical cardiac supports, and they found out that there is a better survival rate. In severe peripartum cardiomyopathy with hemodynamic instability despite ionotrope, temporary mechanical cardiac support is there as a bridge to recovery, and this is suggested in the European Society. Now next one is occurrence of arrhythmia is in a case of peripartum cardiomyopathy. Any sort of arrhythmia is possible. VT happen, VF happens, atrial fibrillation happens. These all are the literatures that says that the occurrence of the arrhythmias are high in such case. So we can go for either pharmacological cardioversion, can be used in case of stable VT. So the drugs that may be safe is like amiodarone, lidocaine and procanamide can be used. Electrical cardioversion can be used. We will always feel doubtful to use electrical cardioversion to a pregnant female because we may harm the child. So that is not such things are not there. Minimal current reaches the fetus. And one thing is like if you deliver some DC cardioversion, like do one fetal viability check after that. That's it. And one more thing, like if you are placing the pads for giving the shock, what you should do, you should keep it a bit far from the breast. That's all. Next one is like implantable cardiac defibrillator versus wearable one. What they found out that most of these risk factors, this disappears after a period of 6 months. So instead of implanting a defibrillator, which itself is again can lead to infection and all those things, what they found, start using a wearable defibrillator and wait for 6 months for going for a permanent device. So ICDs are best reserved in patients with peripartum cardiomyopathy without LV recovery after 6 months. Next one is like what mode of delivery we should go. We should go for a cesarean or we should go for a normal vaginal delivery. So there is no hard and fast rule. So the things are simple. If the pregnant female is hemodynamically stable and you feel you can support it, then go for vaginal delivery. And if the patient cannot be stabilized, then it should be dealt with urgent cesarean section. And if we are going for a vaginal delivery, try to cut short second stage of labor with devices. That is one thing we can do. Now about the safety of lactation. See, the thing is like, see, lactation actually needs a lot of raises the metabolic demands and can worsen the heart failure. So in a case of severe heart failure, we don't recommend the use of we don't recommend lactation because it got a 2B indication. And in patients who are on bromocriptine, we should stop this thing. And the other thing is like the drugs, like some AC inhibits sacubitril valsartan that have got unknown effect on the baby. Then the other thing is like ivabradine has unknown data. Then along the directly acting oral anticoagulants also don't have any specific data for it. So now let's go to the investigational therapy. So everybody will be interested, like, see, investigational therapy is going to do something. I'm so sorry to say, it is of no use. See, these are the things, because my topic was containing the, like, I have to say something, that's why I brought up these 3 slides. One, they found out use of immunosuppressive therapy, that is only beneficial if it is myocarditis. So by definition, it is not a case of peripartum cardiomyopathy, so that is not there. Next one, IVIG in peripartum cardiomyopathy, there are some single centers that tried it. Again, some benefit was there, but it is not yet documented through any RCT, so again, it is of no use. Then this is one microRNA 146A. That is one thing I was showing in the flow chart. Actually, what they found out, this in animals, this is of use. It has not been yet translated to humans, and what they found out, if we are using this one, the breastfeeding can be continued. That's what they found out. But again, it's yet to be translated to the humans. So now I have done with the acute part. So basically in acute part, what we have to do, we have to stabilize the patient, we have to decongest the heart, we have to reduce the preload, we have to reduce the afterload, we have to select the, use the drugs judiciously. Bromocriptine should be selected. The dose duration depends upon the type, and you should never be hesitant to go for the mechanical cardiac supports, and inotropes and all should be given whenever it is needed. Now, next one is like the long-term management of peripartum cardiomyopathy. So basically, if there is if the ejection fraction improves above 50%, then it's recovery, and so you can use EORP PPCM recovery score that will help us to predict the recovery, and it is based on the ejection fraction, left ventricular end diastolic volume, QRS duration, preeclampsia, and HDI index. Based on that, this score is there. Then next one is like, see, you are starting a young female on multiple drugs. So now the next thing is like, and you are treating it as a heart failure. So is it a lifelong treatment? No, it is not. You can wean off if the patient start to improve. So consider weaning only most important if ejection fraction improves more than 50% and for more than 6 months, you can start weaning. And you need to have a close follow-up, actually like every 3 months, echocardiography every 6 months. And always follow a stepwise protocol. Never be like, we'll withdraw 2 to 3 drugs simultaneously. No. We will go slowly, like start with spironolactone, stop it, continue the other drugs like beta blocker and ACE, because then after 6 months, if stable, then stop ACE bar ARB. Then finally, and the last drug to be tapered off is like the beta blocker, and diuretics we can stop at any particular point if you feel the patient become euvolemic. And reintroduce we need to keep on frequent follow-up, because what happens is like, suppose at some particular point you weaned off the drug, and again the patient can in fact go back to the heart failure. So that is one important thing. The next one is durable mechanical cardiac support. This is for those kind of population who, what happens is like, this recovery won't happen in 6 months as expected, and it will take some more time. So in that stage, you can use left ventricular assisted device, BiVAD or total artificial heart. We can use it either as a bridge to recovery or bridge to transplant or as a destination therapy, depending upon the patient status. Like bridge to recovery means we will give time so that the patient will improve, or if you find out the patient's condition is so bad that she's listed for transplant, and we will continue the support till the patient receives a heart, and the destination therapy is like, if that's not suitable, we'll go for that. Now next one is like cardiac transplantation. The cardiac transplantation has been also been done for this. This is reserved for the refractory heart failure despite the maximal therapy, and the survival rate is also relatively good. 5 year is around 66, and 10 year is 49, and 15 year is like around 40%. And always most important, refer this case to the centers with good report, good data. See, never try to hold this patient, try to do circus. So refer these patients who have experience with the data and let them do it. So because it's a young female, so then future pregnancy. See, the most important thing, like if the fully recovered, again ejection fraction came above 50%, the relapse risk is about 24%. And so in case of a patient whose ejection fraction, the patient started clinically getting better and the ejection fraction is still below 50, avoid future pregnancy. What happens is like the relapse rate is around 40%, and going for mortality is somewhere around 20% in that case. And in case of subsequent pregnancy, always have a vigilant watch, do echo in every trimester, early postpartum, and close monitoring for heart failure symptoms. So this is the final summary slide actually. This is actually the board scheme. Whatever I have told till now is been summarized in this single slide, and this is what the European Society recommends. They say bromocriptine, give bromocriptine as per the dose, then oral heart failure drugs based on the pregnancy as well, based on the whether the child is delivered or not, then anticoagulation, at least in the prophylactic dose, then relaxants and diuretics. So that's it. Now let's go for that questions that I put earlier, right?
Thank you, Dr. Jidesh, for that wonderful session. A perfect blend of evidence, experience, and bedside wisdom in handling this delicate condition. Now over to our chairpersons for any remarks or additions.
Thank you, Dr. Jitesh, for such a wonderful talk. Actually summarized everything about peripartum cardiology. It was a very good review with pathophysiology as well as the clinical aspects and advanced management of peripartum cardiology. As it has been highlighted in the presentation, this is a very tricky situation wherein a young lady is presenting with heart failure, and it has to be tackled as stress in a multidisciplinary approach to be handled by even the gynecologist and the physician and cardiologist. So altogether, because it involves a newborn as well, and the medications which are used for this are often harmful to the many eyes of patient as well as the kid. It is very tricky to go about with the management, and it has been wonderfully explained throughout the presentation the challenges we face with the management of peripartum cardiopathy. So one most important thing is that always have a psychological counseling for these type of patients, because they are elderly patients who have just given birth to a child and they are suffering from shortness of breath. The one aspect is always to improve the psychological counseling for these patients. So now we'll go back to the slides which were presented to us with the questions which were given in the initial part of the presentation. Actually, these questions are pretty tough for
See, actually, I thought of putting these questions just so that they will know what to listen. That is the only reason. I know some questions are a bit how will you deal? So basically, the main crux behind this question was like how to reduce afterload. So everybody will go for AC inhibitor. So what the drug is like hydralazine and isosorbate. So that is the thing, because that can act as a replacement. See, same like in a case of CKD. So then again, the next question.
Sir, actually we are running out of time. Can you please wind up?
And this is like patient is having sinus tachycardia. The preferred beta blocker is like start with metoprolol and or never go the other way. Start with a higher dose and go down is not the thing. Always go with a lower dose and titrate accordingly. Then the strongest rationale for using bromocriptine is like it prevent the endothelial toxic 16 kilodalton thing. In peripartum treated with full anticoagulation is required because bromocriptine is prothrombotic and that is independent on ejection fraction thing. Then so basically the patient is ejection fraction is low, patient is having low output cardiac failure, and what will you do? Put the patient on mechanical circulatory devices. Then if the patient requires ventilatory support, what we should do? We should use we should avoid a sudden decrease in preload, avoid aggressive PEEP. Regarding ICD timing, it is after 6 months. Then again during the labor, early epidural analgesia with assisted second stage. And in patient with ejection fraction of 48, what we should do? Pregnancy should be discouraged as the cutoff is 50. That's it. Thank you.
Now I request Dr. Jalil, consultant anesthesiologist from MES Medical College, to kindly present the memento to our speaker, Dr. Jitesh Gangadharan. I also request Dr. Nandakumar, consultant gastroenterologist from EMS Memorial Cooperative Hospital, to present the mementos to our chairpersons as a token of gratitude. Thank you, sir. Our next topic focuses on the moments that often decide a patient's fate. Those early signs that whisper before they scream, catch before the crash, mastering red flags. This session will be delivered by Dr. Abhay A.S., HOD and Consultant Intensivist, Department of Critical Care Medicine, Maulana Hospital. I warmly welcome our chairpersons, Dr. A. Shaji Abdul Ghafoor, Consultant Physician and Diabetologist, and Dr. Linsha P., Registrar, Critical Care Medicine, KIMS SHIFA, to please join us on stage.
Good morning, all. At the outset, I thank Prem Kumar and the team for arranging such a wonderful critical medicine evening. Today's topic is Catch Before the Crash, Mastering Red Flags by Dr. Abhay. We all know we have to identify the red flags before a patient comes to the critical care division, because the intervention is very important before the patient crashes into respiratory arrest or cardiac arrest. So we'll be hearing more about this from Dr. Abhay or to Dr. Abhay.
So, hail and hearty good morning to all. At the outset, I would like to thank Dr. Prem and KIMS SHIFA for giving me this dais to speak on this good topic. And truth be told, at the outset, when I actually got the topic, it gave me a crash because I did not expect this. But it's a good topic, and it's going to be challenging for me to engage everybody, because I think everyone would already be a masters of the red flags. It's just about how to coordinate and how to use it and employ it and apply it. That is a challenge, actually. So I'll just go into detail once the PowerPoint is ready. So I shall begin. So unexpected deterioration is most commonly, as we know, will occur in wards, and ICUs are not completely exempt actually, and it actually results in cardiorespiratory arrest, as we all know. However, more than 70% are actually preceded by abnormal vital signs, and this is by more than about 6 hours. So we know now that crashes are detectable, they can be preventable, and time matters. So now we have established that. And hence our core philosophy should be something like this. Every cardiac arrest is a system's failure unless otherwise proven. So this should be our core philosophy. And keeping this in mind, our goal should be obviously to implement a system aimed at patient safety, that is to prevent such crashes. So how do we achieve this goal? So that would be the main topics I would be covering. That is the rapid response system, or the RRS, early warning scores, how to implement them in practice, a concept called failure to rescue and some scenarios. So rapid response systems actually is aimed at delivering safer patient care, which is the monkey in the middle. And the monkey is actually having two limbs, the afferent and the efferent limb, a head, which is the administrative limb, responsible for providing resources, and a tail, which is the quality programs and quality department, in fact, which develops collect the data and report them and helps in the feedback. The afferent limb is actually consisting of the primary ward team, who's going to actually see the patient first and what they're going to do with the patient, how they're going to detect the abnormalities and identify deterioration and alerting the, escalating the care. The efferent limb would be probably the ICU fellows, the ICU personnel, and the persons with expertise in dealing with acute medicine who actually respond to the call, and the equipment that they subsequently bring. And coming to the afferent limb, so their role is very simple. They're going to identify the deterioration, they're going to trigger a response, and the response is usually escalation. Very simple. And this includes the criteria for activating the rapid response team also, and the early warning scores as well, and the mechanism of how they activate. So a brief review about the early warning scores. It's nothing but a bedside scoring system. It aggregates routine vital signs that is actually easily measurable into a single numerical score, and this is going to help detect patient deterioration early and going to trigger a graded clinical response according to the score. And all these numerical scores are designed in such a way that the higher the score, it's bad, simple. And this concept was first been around since 1990s, and throughout the period of time, the scores have evolved from a Muse score to a new score, and now the recent version is the News 2 score, which has been validated in 2017. And that subsequently has evolved throughout the NHS. It's a global standard now, and it's used in many countries as well, and even in some institutes in India as well. So briefly about the history of some early warning scores. Again, we may all be familiar with some scores like the Muse. You may have heard of it at least. Then there's the QSOFA, there's the ROX index, which became famous in COVID. So among all that, the main thing was, since the concept of the early warning scores, they started implementing it all through the NHS. But all of them used different scores. And then the NHS actually does something good. They actually audit if what they're doing is good. So what they found out was by mid-2000s, there was an alarming trend. That is, more than 50% of cardiac arrest and deaths are actually preventable. And it's still happening, even with all the early warning scores. So again, the Dr. Brian Williams was the hero here. He's a physician in NHS, and he audited a large number of data. He identified common physiological variables that actually can predict stuff, and he invented a score, NEWS. It's called the NEWS score, the National Early Warning Score. Now the problem was, again, as usual, everyone rejected it. Everyone is like, no, you can't group everyone into one score. It's not possible. One size doesn't fit everybody. And so he again went back, modified it, and he validated the NEWS score. That is a NEWS 2. And that, in its recent version, has gained popularity and is now employed throughout the NHS. So this is the first iteration of the NEWS score. So it employs something very simple, the respiration rate, which is usually, from what I've seen, no one measures it properly, the respiratory rate. And that's the most important sign. Then there's the oxygen saturation, the supplemental oxygen required to increase the oxygen saturation, the temperature, the systolic blood pressure, the heart rate, and the level of consciousness, not by GCS or anything, but the AVPU scale, the alert, verbal response, response or unresponse to pain scale. That's it. Very simple. And what did they do in the NEWS 2 score? The NEWS score came across a lot of criticism because the oxygen supplementation, resulted in a lot of hypercapnic respiratory failure in COPD patients. So they implemented 2 scales for the oxygen saturation. And then they also said the AVPU scale misses the confused patients. So they implemented that as well. They incorporated confusion into the AVPU scale. That's the only difference. So the NEWS 2 is nothing but a better version of the NEWS score. Again, how are they going to score this, and how are they going to escalate response from this? It's very simple. This looks very complicated, nothing like that. Grade 0 means keep monitoring 12 hourly. Grade 1 to 4 means do more monitoring 4 to 6 hourly, and make sure the seniors are involved. like the registered nurse, the nursing supervisor, etc. Once you reach a score of 3 at any one single scale, escalate. Talk to your primary treating doctors. That's it. 5 or more, an aggregate score, make sure the nursing supervisor is involved, the primary medical team is involved, escalate to a person who's trained in acute medicine, most commonly the ICU personnel, and ask them to assess within 1 hour probably. And anything 7 or more, do a continuous monitoring, please. Escalate again, call everybody, convey to the proper mechanisms involved or whatever. Make sure the acute medicine personnel is going to come and review the patient within half an hour. Make sure that the patient is shifted to a level 2 or level 3 facility or an ICU. Make sure that a senior clinician also comes and has a review. That's it. It's very simple. So, then you will be asking me, is it really practical to teach all this to the staff? Even I would say no, it's not really that easy. But actually it is. It's actually just going to tell you to do something very easy. That is the spirit of News 2. That is just look, listen, and touch the patient. That's it. That's all you need to do. Look at the patient, get the respiratory rate, look at the monitor, get the saturation, the heart rate, the BP. Listen. Is the patient confused or not? Then touch the patient. See if the patient is cold or clammy. If so, trigger the response. Just escalate. It's very simple. It's nothing complicated. So again, early warning scores are not infallible. Even with adherence, it fails. So why does it fail? Most common, the human factor. Actually, we fail. That's the problem. The anchoring bias. We stick to the first impression. That is a patient with tachypnea. We'll think, oh, the patient is anxious, especially if the patient has a past medical history of psychiatric disorders. Then there's the triage queuing, where we over-rely on initial cues. Maybe elderly patient on antiplatelets has a fall. So you'll treat the orthopedic part and just leave it there. No, but the patient may have a head injury and you're going to miss a SDH. So take a CT also. Don't queue and forget. Then there's a shift change drift that we often see in the ICU. The night shift is tired. They'll receive a patient the early morning. They maybe miss a lactate and rising trend of lactate, and then they're going to classify the patient as stable. Give the same handover to the day shift. The day shift is going to ignore the patient. Patient subsequently crashes. So that is a human factor. Then there's a family red flag. Actually, often we've come across a family who's going to tell you, the patient does not seem himself. He looks bloated. His face looks neerugudi, they'll say. And we actually dismiss them. Oh, they're just over-worrying. We dismiss their gut feelings. Actually, this is one of the strongest predictor of a crash. And then you'll ask me, is there evidence for this? Yes, actually, yes. It's called Ryan's rule. And in 2025, in a Lancet cohort, what they found out, caregiver concern predicts critical illness, ICU admission and ventilation, even after adjusting for abnormal vitals. And it has been confirmed in the pediatric population in the study below as well. Then, of course, we can augment all our feelings and everything with tech, and that is the AI involvement. So AI algorithms, they crunch all the data. I'm wearing a Galaxy smartwatch now. It monitors the heart rate, BP, everything it monitors. And there's the Massimo Radius, the Evirion. And they actually, what they do is they trend data. They pick up early, more than a human can possibly do it. And even lactate monitoring is now capable via sweat sensors. And is there evidence for this again? Yes, in post-operative patients and COVID cases. But again, with subsequent amount of time, I think as time passes, there'll be more. So what other indicators can we use along with the News 2? Is it going to be all inclusive? Definitely not. Obviously, nothing can incorporate everything. So just make sure you add a panic button when the family says something. Make sure you trust the senior nurses. It's very important. They'll have gut feelings. They'll tell you before the vital signs. They'll tell you something wrong with the patient. Look at the fluid balance. It's so important. It's going to detect fluid overloads before anything else. Look at the pain. Pain is an important vital parameter, and it's not involved even in News 2 score. So even ischemia is one of the first signs is pain. So remember that. And then there is the neurological observations. If the patient is a bit encephalopathic, if this develops a weakness. Again, capillary blood glucose and ketones can be incorporated into that, and rising oxygen requirements are definitely alarming. Coming to the efferent limb. Efferent limb is what the ICU person is usually the person who is part of the main part of the efferent limb. It could be a respiratory therapist, could be an ICU nurse, but it could be ICU fellow. And the equipment that they bring to the response. This represents the efferent limb. And again, these are actually called the MET teams, the medical emergency teams, or the RRT, the rapid response teams. And the MET teams are what's usually called in Australia, the RRTs maybe in the West. And larger teams, usually such teams will consist of at least one critical care physician or a fellow. So what is this difference between the MET and rapid response teams and a code blue team? It's very simple. When the patient crashes, there's nothing recordable, it's a code blue. And the mortality is very high in that case. Usually, even anesthesia fellows are involved, and the patient is usually in cardiorespiratory arrest in a code blue team. In a rapid response team, the benefit is the patient is not dead. Simple. There's a low blood pressure, there's a rapid heart rate, there's a respiratory distress. Patient may have an underlying diagnosis of sepsis, pulmonary edema, arrhythmias, respiratory failure. Usually, the treating team is an ICU fellow, ICU nurse, respiratory therapist. You can have a higher call rate because of early detection. You can reduce mortality and it's shown to have around 0 to 20% after they are called. So you can actually save a patient. And this is an example of a MET team, maybe a poster that is seen in Australian hospitals. And what they do is just arbitrary. They have just arbitrarily made a breathing rate or maybe an oxygen saturation or a pulse and urine output. But the thing is, they have made something that is going to trigger a response. So that's the main thing. They've implemented something, and it's going to be employed throughout the hospital. So what are the scoring system that ICU personnel can use as part of the efferent limb? So this comes as the first domain I will talk about is the respiratory, where this is the ROX index, which is nothing but this SpO2 by FiO2 divided by the respiratory rate. And this actually is more useful in the HDU, where HFNCs may be used. And escalation trigger is usually less than 4.88. When the score comes less than 4.88, go ahead and intubate. In hemodynamically, shock index, this is one of my favorite indexes, heart rate by SBP. It's going to actually detect shock before the BP actually falls. So that's so useful, especially in the emergency department. Then there is the sepsis, the Q-SOFA score, where the RR, the SBP, and GCS can be quickly calculated, and you can escalate care subsequently. Then there's the VEXUS. Again, it requires a bedside ultrasound, but you can detect AKI risk, you can detect venous congestion, and again, escalate care when grade 2 or more. So what is the evidence for, again, all of this, the rapid response teams? There's just one RCT. It's called the MERIT trial. It was so well conducted that, as usual, it could not detect any benefit. So the primary analysis showed that implementation was not associated with decrease in cardiac arrest, ICU admissions, or unexpected deaths. Then only post-hoc analysis showed some improvement. Now, why was this? Probably because the duration of the actual study was very small, so it could not really detect a large difference. That's the basic thing. Later studies, however, have showed some benefit, especially in low resource settings. There have been systematic reviews of around 20 plus studies, and it did decrease in ICU transfers in pediatrics. And again, tech integration with RRS has actually showed detecting patient deterioration 2 to 3 hours earlier and cutting failure to rescue events. So what is failure to rescue? I'll explain that. So what are the challenges that we face in implementing an RRS? It requires implementation over at least a year to have some effect at least. And mortality benefit is still suspect. The institute that I have worked in employs a RRS since several years, but they don't really publish it. They're not bothered because they know it's so good. So they keep using it. So we don't have access to that data. And the role is actually to make sure that you have a quick second opinion, not to take over the patient. And it requires continuous education and re-education of ward personnel. Again, everything that is implemented requires audits to run successfully. And you need a high response dose, that's around 25 calls per 1,000 admissions. So how to implement this in your institute? Just 30 days, that's all it actually takes. Step 1, contact your admin, contact your quality department, the head and tail of the monkey. Step 2, form a scoring system sheet. It need not be news to, make your own or make news to itself. Train your ward staff to relay properly, get personnel for reacting properly. Step 4, incorporate a family panic button. Step 5, actually save a life and audit it and see if it's actually useful. If so, continue. And what is this failure to rescue that I've mentioned twice? It's nothing. It just describes failure or delay in recognizing and responding to a hospitalized patient expecting unexpected deterioration. And why does this actually occur? Again, I think the 3R paradigm is actually self-explanatory here. There's a patient unwell, we fail to recognize, or we fail to relay that recognition, or we fail to react it to that. And that results in failure to rescue and patient crashes. So at each level, there may be problems. For example, in failure to recognize, there may not be adequate staff. The adequate staff may not have adequate early warning scores to detect it, or they may not have enough training. Then surveillance, other than surveillance, the medical emergency and rapid response team, they may not be aware there's a med team that is available to help. As far as relaying information goes, I think it's very obvious that no one knows how to relay properly. It should be quick and succinct. That is the S-bar way of communication. That should be easily followed. Then there's the failure to react. They may not be adequate ICU personnel, or you may not have actually appointed a person to react to this. So that results in this failure to rescue. Again, talk would go amiss without mentioning AI. Again, continuous risk prediction is what they do from real-time vitals, labs, and clinical notes. They detect subtle deteriorations earlier before us clinicians. They recognize trends. They generate risk scores and prompts escalation. Again, it's just a support system as of now for nurse, physician decision-making. And what domains are they actually responsible for, have they been tested in, is actually the vitals, where they learn the trends and detect deterioration. In sepsis, early detection, again, we know it helps in mortality by giving earlier antibiotics. In respiratory wise, again, HFNC or NIV failure can be detected early. In hemodynamics especially, the research is ongoing, where shock prediction is actually a big thing nowadays and avoids occult hypoperfusion. Again, integrating AI into workflow can help in smart alerting and reduce over alarm fatigue. So what are the advantages with this AI now? It detects early and pre-arrest interventions are possible. It integrates data streams, standardized surveillance, and helps in judicious allocation of resources. Now what are the limitations? We ourselves don't know how they work. We can't really explain. That is the problem. And the quality of data that they're fed, we don't know how good they are. And again, they may keep over-alerting. That is also a bad thing. And again, it's tough to integrate AI into already established systems. That's a big challenge. So my conclusion would be charts catch around 70%, but human, tech, and families catch the rest. And together we, if possible, will try and achieve at least 95%. And keep auditing one trap, and your failure to rescue will thank you. Now coming to 2 scenarios that I've prepared just to demonstrate. Maybe that's so that we can catch a catch like jaunty. In a ward patient, post-operative day 3, post-laparotomy for perforation peritonitis, background history of COPD on supplemental oxygen. The 8 o'clock vitals are very rosy. 3 hours later, he has a desaturation. He has a respiratory distress around 28 per minute. His heart rate has increased. There is increased accessory muscle use, and chest auscultation reveals Krebs. So what are the red flags here? We know there is rising RR, rising oxygen requirement, falling saturation. The NEWS 2 has increased from 2 to 7. So again, it's a high risk. You need to shift the patient to ICU. And the ICU personnel have to come and actually escalate oxygen requirements. A better oxygen delivery device needs to be done. They can actually implement a ROX index if the patient is in the HDU. And you can always go ahead with an ABG, take a chest X-ray, and then make sure someone is informed. The escalation part is the most important, and whom you are escalating to. Scenario 2, catch the cash like David De Gea. In ICU step down, the patient is requiring from septic shock after a cap, and who's off vasopressors maybe 8 hours previously. Initial vitals are again looking good. Mid-shift after maybe 4.5 hours, again the heart rate has increased. There is a slight hypotension compared to the previous value. Mild increase in tachypnea. Output has decreased, lactate has increased. Again, you can apply the shock index here. It has increased to 1.2. The MAP is decreased. The NEWS 2 has increased. there's a lysine lactate and an oliguria. So the most important thing is here is to recognize the trend, activate the response. The referent limb, the ICU person is going to come. They're going to attend the patient. If possible, preferably they would have an ultrasound. They should do a vexus. They should rule out underlying cardiac dysfunction, see if fluids are ideal or inotropes, and make sure the patient shifted to the ICU and optimize the map. So that concludes my talk. Thank you.
Thank you, Dr. Abhay, for that sharp and eye-opening talk. A strong reminder that recognizing subtle red flags early can change the entire trajectory of a patient's outcome. Now over to our chairpersons for any remarks.
Thank you, Abhay. It was a wonderful talk. You have covered use to how to implement, how to catch the red flags before the patient crashes. It was very nice presentation. Any questions?
So the RRS is for the ward. The news tube is just a sheet. It can just be incorporated in a file. So this is for the ward systems. It is not for the HD or the ICU. Because HD or ICU will have continuous monitoring systems available. So I believe the news 2 is more than sufficient for that. Yeah. So if there is a feeling, that's the family trap. Escalate. Yes. So it should be part of the file. You are admitting a patient, the patient should have a news 2 score sheet within the file. All patients.
What about all the patients who are coming to the emergency room will do use to?
Sir, in the emergency room, I would trust the emergency physicians more and the emergency nurses more. I don't think news 2 is applicable in that scenario. I think they would actually rapidly do it on bedside itself. Actually, I think there are a lot of emergency physicians here. I think shock index is actually incorporated into them already. They would, I think, detect it very fast from what I've experienced, sir.
Hospital, you are using any technology, newer technologies?
No, sir, none. Even the basic news 2 score I have not been able to implement actually. I need to.
Thank you.
I now request Dr. Mohandas from Ramdas Clinic and Nursing Home to present the memento to our speaker, Dr. Abhay AS. I also request Dr. Madhave Joshi, HOD and Clinical Professor from Department of General Medicine, KIMS SHIFA, to present the mementos to our chairpersons. Thank you, sir. Up next, we have someone who really doesn't need an introduction, our own HOD and constant guide, Dr. Prem Kumar PS, Senior Consultant Intensivist, Department of Critical Care Medicine, KIMS SHIFA. Sir will be talking about something we all face in the ICU practice, those tricky situations where the guidelines end and our judgment begins. The topic is gray zone decisions, critical thinking when evidence ends. I take this opportunity to welcome our chairpersons, Dr. Sujit S. Nair, Senior Consultant Physician, Maulana Hospital, and Dr. Ashwin Ashok K., Pediatric Intensivist, KIMS SHIFA, to kindly take their seats on the dais. Over to you, sir.
Good morning, everyone. First of all, we congratulate Dr. Prem and his team for organizing this wonderful conference. As the MC told, the speaker doesn't require any introduction. He is well known to us. He is a very good writer. And the topic of race of decision, critical thinking, sometimes matters most. We all know, I think, most of those who are sitting here used to watch mystery thrillers or used to read mystery stories. Similarly, there are some fields where we have to judiciously take apt decisions. Here, I invite Dr. Prem Kumar to unfold a mystery. Thank you, sir. Over to you.
Thank you, chairpersons, for your introduction, and thank you all for coming here today for this critical care CME conducted by Department of Critical Care Medicine, KIMS SHIFA. The topic I am going to speak is gray zone decisions, critical thinking when evidence ends. What I will be doing is I will be presenting a case which we come across routinely in our clinical practice. And over the next 30-45 minutes, I will try to explain the inadequacies of guidelines in many situations we deal with routinely. How clinicians with the differing clinical expertise and knowledge differs in their thought process and decision making, and how to make the right decision by critical analysis of patient clinical status. Before going to the topic discussion, I don't have anything to disclose with no financial conflicts of interest. And all the images of persons used in this presentation are AI generated. Now, the practice of medicine has evolved over the last few decades. In the past, it used to be about the knowledge of the physician, his expertise, and what is known as intuition. But since the last 2-3 decades, the focus has shifted to what is known as evidence-based medicine. But the problem is in the name. The evidence-based medicine gives you a feeling that clinical medicine is evidence-only medicine, but that's untrue and that is unfortunate. Because even the core elements of the evidence-based medicine, it includes research evidence, which is brought to you by various guidelines. Those guidelines are based on various strength of evidences in those randomized controlled trials and various studies. But equally important is the clinical expertise of the clinician dealing with the patient. That is very important because we know the treatment and the decision making many of the time won't be appropriate if you go by evidence-based medicine alone. And the third thing is that patient values, okay? That is also important because you make a treatment plan, but then the patient will be having different ideas. We know that some of the patients with certain religious beliefs, they won't be agreeing for blood transfusion. Some of them won't be willing for intubation, some of them won't be willing for dialysis, and then you need to take into consideration their choices, their wishes, and then try to make a treatment plan. And evidence-based medicine is an integration of all these three for optimal care of the patient. So the case I am going to discuss is actually a case which came to our department few months back. She was a 39-year-old female. She was a diagnosed case of type 1 diabetes mellitus, diagnosed at the age of 10 years, and she is a known case of hypothyroidism. She was on insulin pump and replacement doses of levothyroxine. The previous day of presentation here, she had multiple episodes of vomiting, and then she became tired, complained of tiredness. And next day morning, she was found to be drowsy, and the husband assumed that she was drowsy because low blood sugar, and he switched off the insulin pump and took her to a local hospital. In the local clinic, she was found to have very high blood sugar, and they gave some treatment and then shifted here for further management. Now, on admission in our ER, she was drowsy but responding with a Glasgow Coma score of E3, M5, V4, total of around 12 out of 15. She was hemodynamically stable. Her pulse rate was 122 with a blood pressure of 120/80. She was grossly tachypnic, acidotic type of breathing with an RR of around 46 to 50, but she was maintaining normal oxygen saturation and room air. She was afebrile. Her other system examination was normal. Labs done from the ED, the major abnormal results, I have made it in the bold letters. The random blood sugar was 612. Blood ketone level was 4.9. Her creatinine was 1.7. Potassium 6.4. And the blood gas that you need to keep in mind, because the further discussions will be on these values. Blood gas showed a severe acidosis with a pH of 6.762. The carbon dioxide level was 11.7 only, around 1/4 of the normal value. That means she is extremely hyperventilating. Bicarb level is only 1.6. You know the normal value is 24, that is only 1.6. So this ABG value, the pH of 6.76, carbon dioxide level of 11.7, and bicarb of 1.6, please try to keep in mind. Now, what is the diagnosis? It's simple, straightforward diagnosis. It's a DKA. Just to highlight what is the ADA guideline, I have put the slide. ADA guideline says for DKA, there should be 3 criteria. That is, one is diabetes. The glucose level should be more than 200, or a prior history of diabetes alone is sufficient, whatever be the blood sugar value. And then there should be ketosis, which is manifested by ketone body level, beta hydroxybutyrate, more than 3 millimoles in the blood, or if you are using a urine strip, ketonuria more than 2+. And there should be metabolic acidosis. How to diagnose metabolic acidosis? The patient should, pH should be less than 7.3, or bicarb concentration should be less than 18. So this patient fits all these 3 criteria, and it's a straightforward case of DKA. So how to manage? You need to follow the usual DKA management guideline. But myself being an intensivist, my focus should be broader. Like I need to tackle this patient's diabetic ketoacidosis, but I need to find out what are the most life-threatening issues that is present in this patient, and I need to prioritize my management strategy to tackle those life-threatening scenarios. So what are the most life-threatening issues in this patient? The presentation on, you examine the patient, the first thing that strikes you is the severe tachypnea, okay? Though the patient is maintaining oxygenation, the severe tachypnea, if somebody who has worked in a critical care or any ICU, you will be worried, because over a period of time, this patient cannot sustain this much amount of tachypnea over a period of time. The respiratory muscles are going to get fatigued, and this patient can develop type 2 respiratory failure and respiratory acidosis at any point of time. So that is one thing you will be worried about. And then second thing is the pH. The 6.76 pH is a very, very low pH, and that will be a very important thing you need to tackle. And then hyperkalemia with a blood potassium level of 6.4. So the management, I am not going into detail regarding how to routinely manage the DKA. That is one with regard to IV fluid, and then insulin, and then there is regarding hyperkalemia or hypokalemia management in DKA. All these 3 things I am not going into detail. But there is a mention about bicarbonate therapy. Whom should be given bicarbonate therapy? The guideline says that if the pH is less than 7, you can give bicarbonate therapy. So that's about it. I am not going into detail. So now my priority will be in addition to managing the routine protocol or following the routine protocol DKM, I'll be prioritizing how to tackle these life-threatening issues. So the first life-threatening issue we spoke is regarding the severe tachypnea. Okay, it is due to severe acidosis, but the tachypnea, you know, over a period of time, you can't sustain that effort, and at some point of time, patient will develop type 2 respiratory failure. And already there is a severe metabolic acidosis, and if the patient develops a superimposed respiratory acidosis, the outcome will be very, very bad, and you can expect the patient crashing at any point of time. But what about the guidelines? Do they mention anything about intubating this patient with the DKA? No, there is no decision or no guideline mentioned in your ADA or whatever bit. So the decision is now left to the treating doctor's clinical judgment. Okay. But what about the judgment? The judgment depends upon your knowledge, your past experience, and what is known as critical analytical ability of the clinician. You need to analyze what is the present problem and need to find out the best way possible. Okay, so the knowledge and experience matters in decision making. That is not only in the medical field, it is there in every other field, and that is known as Dunning-Kruger effect. Okay, those who are new to this field had some knowledge, some experience, they will be having what you say, high confidence. That high level of confidence comes from the, they are not aware of what they don't know. That high level comes from their inability or their misunderstanding that they know everything, but actually they are not aware of what they don't know. But as you gain more experience, as you treat more patients, then you know where all trouble can await you, where you can go wrong, and then your level of confidence drops, and then you feel that, no, I don't know anything about this clinical condition. But then again, you see more and more patients over a period of time, you see different complications, and then you analyze where I have gone wrong, which all things I did right in this patient, and the next time some similar scenario comes, you try to modulate your clinical judgment, your confidence level goes up, and then you are likely to take a right decision. That is the Dunning-Kruger effect. The same thing will be applicable in our clinical scenario also. Say this patient comes to a junior registrar, and he'll be asked for hyperventilation or respiratory, you are worried about respiratory muscle fatigue developing. So whether this patient requires a prophylactic intubation or tubing, that is the question asked. So the junior registrar will think, okay, is the procedure necessary in this patient? Is intubation necessary? So he will assess for indications for intubating this patient at this point of time. What are the indications? The oxygen level is normal. Carbon dioxide level, it's not high, it's low actually. So the patient is adequately breathing with more effort, that's all. So is there an acute indication to intubate this patient at this point of time? He'll think, no, we can wait, okay? But what about somebody who has seen such patients in the past, who has come across patients having respiratory distress, waiting, then doing with a crash intubation, okay? He will be worried because he knows this cannot be sustained over a longer period of time. So this patient may develop a superimposed respiratory acidosis at any point of time, and that will be disastrous. So he'll be thinking, what are the consequences if the procedure is not performed at this point of time? He will be worried about that. But then now the question comes to a senior person or somebody who has more experience. Okay, the decision is whether to leave the patient at that point of time like that or to go ahead with the intubation. You have seen, you have heard the arguments of both the two. But you will be worried, what will be the consequences if I am doing the procedure at this point of time? That's how the thought process changes. The first person, is there any indication to do the procedure? The second person, what if I am not doing the procedure? And the third person, what if I do the procedure? That way the thought process changes. So I will try to address this question. What is going to happen if you are going ahead with the intubation? So I will try to assess it in the three sequential ways. The first thing, the intubation what will happen to the PCO2 level? Second, what will happen to if the, what will do the PCO2 level to the acid-base status of the patient? And third thing, what will be the effect of acid-base status change on the clinical condition of patient? I will go sequentially. So what happens to the PCO2 if I intubate this patient? That's the first question I need to address. Now, ventilation in this patient, if you attempt intubation and ventilation, there are two parameters that are going to change. One is PO2 and one is PCO2. That's okay. All other changes are secondary to all effects on this. But PO2, you are not worried. This patient already maintains an normoxia. So you are not worried. You are not worried that the intubation may alter the oxygenation. But the intubation may alter the PCO2 level of this patient. How? So that is answered if you know what is going to happen when you are giving sedation and paralysis for intubating this patient. Now you understand this patient is breathing at a rate of around 46, okay? It's rapidly breathing. The PCO2 level has come from 40 to 11.6. So that means his minute ventilation will be something around 20 liter or more than 20 liter per minute. So each breath he will be taking a large volume like 600 or 800, and the number of breaths are more. But this is happening in 1 minute. Your duration is not getting enlarged, okay? So you are trying to take more air inside the body and trying to exhale, and that has to happen repeatedly at a faster rate. So how this is possible in that patient? This is possible because normally we are passively exhaling, okay? The inspiration happens by active contraction of the inspiratory muscle, but exhalation happens just, it is passively collapsing. But here, if you allow the passive exhalation to happen as normally, you won't be having sufficient time to take more number of breath, larger tidal volume. So in order to have more inspiratory time, the patient changes from passive exhalation to an active exhalation so that the expiratory time is shortened, okay? So expiratory time shortening gives you more time for the inspiration so that patient can take more number of breath, more tidal volume, okay? But the moment you give sedation and paralysis, you are taking away the drive for the respiratory system, okay? The active exhalation which was happening previously, by giving sedation and paralysis, the muscles become paralyzed, right? So the exhalation now cannot be active. It can only be passive. So what will happen? The expiratory time constant increase. So the time for exhalation increase, thereby the time for inspiration is reduced. So your time for inspiration reduces, the amount of air you can take inside, the number of breath you can take inside is reduced. So what ultimately will happen is that most likely the minute ventilation of the patient will reduce. So once the minute ventilation reduces, the PCO2 will start rising up. So that's the first thing. And then you are putting a tube, okay? The tube increases the anatomical dead space, okay? Once anatomical dead space increases, the alveolar ventilation reduces. Once alveolar ventilation reduces, when alveolar ventilation reduces, that also adds up to the carbon dioxide level rise. So both these processes, by giving sedation and paralysis, and also putting the tube, you are creating a scenario where the PCO2 is going to be high. Now, the next step, what does the PCO2 do to the acid-base status of the patient? The second thing. Now, this requires some amount of some formulas, 1 or 2 slides. I know many of us are not very keen or not, we are scared of mathematics. The term itself creates some this thing. So, but I need to take you through 2 slides, okay? The first thing is how pH is calculated. That is the Henderson-Hasselbalch formula. That is pH equals 6.1 plus logarithm of ratio of bicarbonate to the product of carbon dioxide multiplied by 0.03. You need not remember this formula. Only thing you need to understand is that pH increases when bicarb increases and pH drops when carbon dioxide increases. It is inversely proportional to carbon dioxide level and directly proportional to bicarbonate. That much only you need to understand. So in this patient, if you substitute the values 6.1 plus logarithm of the bicarbonate was 1.6 and carbon dioxide was 11.7, you will get a value of 0.66. That is the logarithm. Okay, so adding up, it will give rise to a value of 6.76, which is the value we got in the ABG report. Okay, so just remember pH is directly proportional to bicarbonate, increases with the bicarbonate level and reduces with the rising carbon dioxide level. Okay, and the second thing, little bit more, but this is the last slide regarding mathematics. That is with regard to how to find out the logarithm. Okay, so if two products are getting multiplied, you want to know the logarithm of that product of that multiplication. Say the two numbers are A and B. Logarithm of A multiplied B by B will be equal to logarithm of A plus logarithm of B. That's simple. Okay, so if if a number is getting doubled, multiplied by 2, it will be equivalent to logarithm of A plus logarithm of 2. It will be equivalent to logarithm of A plus logarithm of 2 is 0.3. So if any number is getting multiplied by 2, the logarithm of that number will be a sum of original logarithm of that, logarithm of original number added by 0.3. Okay? And opposite, if you want to divide A by B, the logarithm of A divided by B will be logarithm of A minus logarithm of B. It will be equivalent to, if you want to divide it by 2, it will be logarithm of A minus logarithm of 2. It will be logarithm of A minus 0.3. So what does this mean? It means that if a number gets doubled, logarithm value increases by 0.3, simple. And conversely, if a number gets divided by half, divided by 2 or becomes halved, the number decreases by a value of 0.3. Now in this patient, what are the effects if PCO2 doubles or bicarbonate halves? Okay, just like I told, if any number becomes halved, logarithm value decreases by 0.3. And if any number doubles, logarithm value increases by 0.3. So if in this patient, if the PCO2 rises from 11.7 to a value of roughly around 22, okay, the pH will reduce from 6.76, which is present at this point of time, to around 6.46. I hope it is clear. Okay. Likewise, if the bicarbonate reduces even by a value of 0.8, from 1.6 to 0.8, again the pH will drop from 6.76 to 6.46. Now your procedure of intubation is, now we know that it is going to alter in this alter the PCO2 level of this patient, because the patient is utilizing his respiratory muscles in the maximum possible way, and you can't substitute that passive active exhalation by any mechanical means. Okay, so your PCO2 level is going to be high. And what will happen, suppose the PCO2 rises from 11.6 to 22, what will happen? The pH will drop to 6.46. And now what is going to happen? This patient is going to die. And however aggressive you try to resuscitate this patient, the myocardium is not going to respond because the pH is 6.46 and no drug, nothing is going to work in this patient. So now by God's grace or the patient's luck, you were able to tide over the intubation without any problem. You were moving the patient with a very rapid rate, and you were also doing awake intubation, and somehow you carried over with, you successfully did the intubation. But now you need to ventilate this patient, right? So what is going to the patient's PCO2 level, bicarbonate level, if you do continuous ventilation? Now again, the same problem. If you need to give sedation to this patient, right? And some of the time you give paralysis also. So the need for continued sedation and presence of an increased dead space to the ET tube keeps the PCO2 level high. That goes on, even during the post-intubation phase. But another important thing regarding sedation, the use of sedation, the effect of sedation in this patient. Now, this patient has got a severe acidosis. Why there is severe acidosis? We know it is due to production of DKA, right? Diabetic keto acids are produced. And there is a balance, right? Normally, keto acids are not produced. Now, if keto acids are produced, there is a utilization also. But when the keto acid production is more than the keto acid utilization, keto acids accumulate in the body and you develop DKA, okay? So that balance tilts in the favor of production. If the production exceeds utilization, you have keto acids accumulating in the body. Now, where do these acids, keto acids gets metabolized? They get metabolized mainly in two organs. One is in the brain and one is in the kidney. Around 70% gets metabolized in the brain and around 30% in the kidney. And in both these areas or both these organs, for keto acid metabolism to occur, you need to have availability of ADP, okay? So how ADP is normally produced? By conversion of ATP. So ATP, when ATP is getting converted, when that organ is functioning normally or utilizing energy, then only ATP will get converted to ADP. So your brain has to work in the normal way, your kidney has to work in the normal way. In that period, during those times, these two organs will be utilizing ATP, that will give rise to ADP, and this ADP then will be utilized to metabolize keto acids. But what about if you are giving sedation? If you are giving sedation, you are reducing the metabolic activity of the brain. And when you reduce the metabolic activity of the brain, ATP conversion to ADP won't be taking place. So there will be lesser amount of ADP, then there will be lesser amount of keto acid metabolism. So indirectly, when you are giving sedation to this patient, you are indirectly reducing the keto acid metabolism happening in the body, thereby creating a chance for keto acids to accumulate in more and more quantities in the blood. Okay? So continued sedation makes keto acid mechanism slow down. So will it be wise to intubate this patient at this point of time? The first guy told no need, no indication. The second felt, okay, this patient may go into a respiratory arrest. It is better to prophylactically intubate. And if that question is asked to me, I will be really hesitant because if it happens with your continued treatment, you need to intervene. But at this point of time, if you intervene, you are actually accelerating probably the death of the patient. So it will be masterly inactivity with utmost vigil. That will be the best decision at this point of time. Now, the first thing we tackled whether I will be intubating, how to tackle the severe respiratory distress. We told, don't intubate, keep a close watch, and if needed, you intubate. What about managing the severe acidosis in this patient? That is the second question to address. So the acidosis results from an increased keto acid production and accumulation. There is a balance, okay? Keto acids are produced and they are metabolized. And when the production exceeds the metabolism, keto acids accumulate. And usually it will result in a high anion gap metabolic acidosis that is classically told in diabetic ketoacidosis. But don't think only DK will be having only high anion gap metabolic acidosis. They can also have normal anion gap metabolic acidosis if keto acids are excreted in the body. In order to maintain electrical neutrality, you need to have negative charges accumulating in the body. So the body will try to preserve the chloride ions, so that will create hyperchloremic metabolic acidosis. So if you want to manage the acidosis in this patient, your aim should be to decrease keto acid production. That is the #1 priority. But at the same time, you need to facilitate keto acid metabolism. These are the two things you need to address in this patient. Reduce the production and optimize the metabolism. Okay. So before going into those two things, again, I am going back to the previous slide I have showed you with regard to logarithm. So in this patient, what are the impact of variations in bicarbonate levels? Okay. What if bicarbonate doubles from 1.6 to 3.2? And what if the bicarbonate drops from 1.6 to 0.8? That means either doubles or halves. Okay. A further reduction of bicarbonate by around a value of 0.8, that is a half of 1.6, right? So 1.6, if it gets reduced to 0.8, that is a very minuscule amount, 0.8, please understand. The pH will drop down from 6.76 to 6.46. Now, this is equivalent to a change in the bicarbonate level. If the bicarbonate level was originally 24, if the 24 drops down to 12, the same magnitude change will be there. But here only a very, very minimal amount is sufficient to create that much magnitude change in bicarbonate level. Okay. Conversely, an increase in the bicarbonate level by a value of 1.6 will increase pH from 6.76 to 7.06. Okay. So here you are in a what you say very precarious situation. Okay. Either a small increase will pull you to a safer zone, but a small decrease will be disastrous. So this is the comparative graph of bicarbonate with change in the bicarbonate causing a change in the pH. That red line you can see that is 24 is the bicarbonate level on the x-axis. That corresponds to a pH of 7.4 on the y-axis. And the subsequent lines are everything in on the pH are everything 0.3. Okay, you can see when the bicarbonate drops from 6.3, the pH drops from 6.8 to 6.5. So this concept is very important. So the key takeaway is even smaller bicarbonate reductions lead to larger change in the pH when the baseline pH is or when the acidosis is very, very severe. At that point of time, you should be very, very worried because even smaller change at that point of time will be having a great effect on the clinical condition of the patient. So in this patient, prevention of additional bicarbonate decline is critical. When you are managing this patient, don't, if you understand that here at this point, I need to be very aggressive in preventing further reduction in bicarbonate level. Even 0.8 or 0.2 will be tilting the balance from life to death. So what are the recommended next steps you will be doing? As I told, the priority will be by reducing the keto acid production. How to reduce the keto acid production? Your only way is by giving insulin. Okay? Now, to come to a safer zone, you can try giving bicarbonate. That is written in the guideline also. If pH is less than 7, you can give bicarbonate. Say if the pH rises from 1.6 to 3.2, your pH, if the bicarbonate increases from 1.6 to 3.2, your pH will be increasing from 6.76 to 7.06, which is relatively a safer environment. Okay? Now, how to optimize keto acid metabolism? You need to avoid sedation. You need to avoid sedation and try to optimize the renal function by increasing the blood pressure, by increasing the, renal flow, if possible. Okay. And prevention of development of additional unrelated acidosis developing in this patient. This is all about decay in this patient at this point. But this case, patient can develop additional unrelated acidosis. One is you give large amount of normal saline that will create what is known as a hyperchloremic metabolic acidosis, shock, lactic acidosis, renal failure. Already this patient had a pH of, creatinine of 1.6, but your aim will be, I will try to avoid development or worsening of already existing or additional acidosis developing in this patient. Because, why? Because the bicarbonate is only 1.6 in this patient. So, just want to highlight, many of the time we give large amount of IV fluid, start fluid and you rush fluid. Now, in this case, with a pH of 6.76, bicarbonate of 1.6, what will happen to the acid-base status if large volume IV fluids are given at this stage, okay? So as we all know, normal saline can cause large amount, can cause what is known as a hyperchloremic metabolic acidosis. So you are giving now, say, isolate or ringer lactate. So here you need to understand that you need to reduce the keto acid production. You are giving insulin, but the action of insulin in reducing the keto acid production will be, it will take some time, okay? So it will happen over say 1 hour or 2 hours like that. That suppression won't happen immediately because there is an altered glucagon-insulin ratio and it will take some time. So you give large amount of IV fluid in this patient. The bicarbonate is what? 1.6 milliequivalent per liter. But remember, this patient is already ECF volume contracted, okay? Now you give large amount of fluid. What will happen to the bicarbonate level? The bicarbonate gets diluted. Previously, this value was say present in 7 liter, 1.6 milliequivalent per liter. So if it was in 7 liter, you give 2 liter of fluid, that same amount of bicarbonate now will be there in 9 liter. And what will happen to the content of the bicarbonate? The concentration of the bicarbonate will drop from 1.6 to a lower value. That is the number one mechanism. And you give large amount of fluid, the capillaries are now getting perfused much faster. That faster capillary perfusion causes a drop in the PCO2 level in the capillary level. Once the PCO2 level drops, the intracellular acids which were bound initially inside the cell combined with the protein, now the PCO2 level drops, the arterial or capillary pH drops. So the acids leaks out from the intracellular compartment into the intravascular compartment. So once acids are coming, that will be bound by whatever available bicarbonate is in the body. So bicarbonate will further reduce. So this is the impact of large volume fluid administration at this point of time. You give large amount of fluid at this point of time, the bicarbonate concentration is going to get reduced further. And any small reduction, as I told, is disastrous in this patient. Okay, so is it appropriate to give large volume IV fluids at this stage? Okay, you need to understand, you understand the pathophysiology or what is happening inside the body, you will be very hesitant. If you don't think, you will be giving, okay? How to treat hyperkalemia in this patient? I am not going in detail, it's very clearly there in the guidelines, so I am not going in detail. So what insights can we draw from this? So EBM enables a structured, evidence-driven framework for delivering high-quality patient care, okay? Yet, its effectiveness is context-dependent and may not generalize to all clinical settings. Critical analysis and individualized clinical condition-based decision-making is very important in critically ill patient. And integrating evidence-based medicine with insight is essential for optimal patient outcome. So, the guidelines and evidences you can always search and refer at any point of time. But the domain of critical analysis and critical thinking, that is the one you need to develop on your own. There is no substitute. In future, AI may replace that also, but at this point of time, the right decision making depends not only on evidences, but also on your critical thinking. And you master balance between these two, then you are most likely mastering what is known as success. And thank you.
Thank you, sir. That was brilliant and really thought-provoking session, beautifully capturing the delicate balance between evidence and experience. We now invite our chairpersons for any remarks.
sir. After running short of time, I think we can wind up the session now. Session is concluded.
Thank you, sir. May I now invite Dr. Nandakumar, Consultant Gastroenterologist, EMS Hospital, to present the memento to our speaker, Dr. Prem Kumar, PS.
It all depends upon body weight of the patient and how much is the extracellular fluid volume of that patient. It will be very difficult to assess actually, but roughly you give around 1 mg per kilogram. The thing may rise by around 1. Okay.
Thank you, sir. Now I request Dr. Kasim, pulmonologist from Maulana Hospital, to present the mementos to our chairpersons. Thank you, sir. We will now proceed to the formal inauguration ceremony, followed by a tea break. I now invite Dr. Sharafuddin KP, newly elected President of IMA Perintalmanna, Dr. Mohammad Yahya, Medical Superintendent of KIMS Al-Shifa, Dr. Saeed Faisal, Secretary IMA Perintalmanna, Dr. Abdul Khalil, Consultant Orthopedic and Arthroscopic Surgeon, and Dr. Shahul Hamid, Clinical Administrator and Emergency Physician, to please come to the dais. To begin this auspicious gathering, may I now invite Dr. Prem Kumar PS, Head of Department and Consultant, Critical Care Medicine, KIMS Al-Shifa, to deliver the welcome address.
Good morning. Distinguished Chairperson, Dr. Sharafuddin, respected dignitaries, esteemed faculty members, and my dear colleagues. It is indeed my honor and privilege to extend a very warm welcome to each one of you to this CME on Critical Care Medicine, Intensive 2025, organized by our department. I now welcome Dr. Sharafuddin KP to preside over this inauguration function of our conference. I welcome Dr. Yahya, Medical Superintendent, KIMS Al-Shifa, our chief guest. I also welcome Dr. Abdullah Khalil, Consultant Orthopedic Surgeon, Dr. Saeed Faisal, Secretary, IMA Perintalmanna, and Dr. Shahul Hamid, Clinical Administrator and Emergency Physician, KIMS Al-Shifa. On behalf of our entire team and KIMS Al-Shifa Hospital, I take this opportunity to warmly welcome each one of you who have gathered here for this academic event. We are privileged to have among us a panel of renowned experts and distinguished speakers whose insights will be undoubtedly enrich our understanding and enhance the quality of care we deliver to our patient. I would also like to appreciate the efforts of our organizing committee, residents, nursing staff, and marketing team who have worked tirelessly to make this event possible. I am confident that today's deliberations will be academically stimulating, practically relevant, and truly inspiring for everyone present here. Once again, I extend my heartfelt welcome to all our respected guests, speakers, and participants. Let us look forward to a day filled with learning, collaboration, and meaningful discussion in the spirit of advancing patient care. Thank you.
Thank you, sir, for those warm and inspiring words of welcome, setting the perfect tone for the day ahead. Now, we are privileged to have with us Dr. Sharafuddin KP, newly elected President of IMA Perintalmanna, a dynamic leader and an ardent supporter of academic advancement. Hearty congratulations, sir. Now, I request Dr. Sharafuddin to deliver the presidential address.
Good morning, everyone. On behalf of Indian Medical Association, Perintalmanna branch, I extend my warm greetings to all who have gathered here for Intensive 2025, an academic feast dedicated to critical care medicine. Critical care represents the finest balance of science, skill, and teamwork, where even minutes or even seconds matters, and every decision can change the course of a life. This EME reminds us that the readiness to act in those critical moments must extend beyond the ICU care to every clinician, to every hospital, and every level of care. As the modern medicine evolves, The demands and challenges in critical care are gathering greater than ever, making initiatives like this INTENSIV 2025 vital for our professional growth and for the well-being of our patients. I take this moment to appreciate the entire critical care team of KIMS Al-Shifa Hospital, led by Dr. Prem Kumar PS, Dr. Fiaz Amsad, Dr. Hafiz PN, for conceptualizing and leading this exemplary program. I also congratulate other faculty, Dr. Jitesh from EMS Hospital, Dr. Abhay from Maulana Hospital, Dr. Anurup from Aster Medcity Kochi, and Dr. Ranjit from Apollo Adlex Angamali for their involvement and academic contributions to this CME. My heartfelt thanks to the KIMS Al-Shifa management for their continued support to the academic and professional excellence in the field of modern medicine. To all the distinguished speakers and delegates, I thank you for being part of this effort to strengthen our collective competence and confidence as the modern medicine doctors. Let us make the best of today's academic deliberations, learn from each other, and together strengthen the science and practice of critical care medicine. And let us continue to learn, collaborate, and uphold the values that make the modern medicine not just a science, but a commitment to the humanity. Thank you all. Wishing all the best for this wonderful conference. Thank you.
Thank you, sir, for your thoughtful and motivating words. May I now request Dr. Prem Kumar PS to present the memento to Dr. Sharafuddin KP as a token of gratitude. Now it's time for the formal inauguration of INTENSIV 2025. We are deeply honored to have Dr. Muhammad Yahya, Medical Superintendent of KIMS Al-Shifa, with us to inaugurate today's event. Sir, we request you to kindly inaugurate the conference and address the gathering.
വേദിയിലിരിക്കുന്ന പ്രസിഡന്റ് IMA പെരിന്തൽമണ്ണ ഡോക്ടർ ഷർഫുദ്ദീൻ, സ്വാഗത പ്രസംഗം നടത്തിയ ഡോക്ടർ പ്രേംകുമാർ HOD കൺസൾട്ടന്റ് ക്രിട്ടിക്കൽ കെയർ മെഡിസിൻ, ആശംസാ പ്രസംഗങ്ങൾ നടത്തുന്ന ഡോക്ടർ സയ്യിദ് ഫൈസൽ, ഡോക്ടർ അബ്ദുള്ള ഖലീൽ, ഡോക്ടർ ഷാഹുൽ ഹമീദ്, എൻ്റെ മുമ്പിലിരിക്കുന്ന പെരിന്തൽമണ്ണയിലെയും പരിസര പ്രദേശങ്ങളിലെയും സീനിയർ ഡോക്ടർമാർ, ഇന്നത്തെ ഈ പ്രോഗ്രാമിന് എത്തിച്ചേർന്നിട്ടുള്ള വിവിധ ആശുപത്രികളിൽ നിന്നുള്ള ഡോക്ടർമാർ, ഇന്ന് അൽഷിഫയെ സംബന്ധിച്ചിടത്തോളം ഏകദേശം 1986 75 ബെഡുമായി തുടങ്ങിയ ചെറിയൊരു ആതുരാലയം അക്കാദമിക രംഗത്തും ക്ലിനിക്കൽ രംഗത്തും എക്സലൻസുകൾ നേടിക്കൊണ്ടിരിക്കുന്ന ഒരു വലിയ പ്രസ്ഥാനമായി മാറിയിരിക്കുകയാണ്. എപ്പോഴും ക്ലിനിക്കൽ ചികിത്സയ്ക്ക് പുറമേ അക്കാഡമിക്സിന് ഒരുപാട് മുൻതൂക്കം കൊടുത്തുകൊണ്ടുള്ള വിവിധ പ്രോഗ്രാമുകൾ നടക്കുന്നതിൻ്റെ തെളിവുകളാണ് ഇതുപോലുള്ള നല്ല ഫാക്കൽറ്റി മെമ്പേഴ്സിനെല്ലാം വെച്ച് നടത്തുന്ന ഇതുപോലുള്ള പ്രോഗ്രാമുകൾ. അക്കാഡമിക്സിന് മുൻതൂക്കം കൊടുത്തുകൊണ്ട് തന്നെ ഒരുപാട് മേഖലകളിൽ DNB പ്രോഗ്രാമും MRCPയുടെ IMT പ്രോഗ്രാമും വളരെ നല്ല രീതിയിൽ ജൈത്രയാത്ര നടത്തിക്കൊണ്ടിരിക്കുന്ന ഒരു ആശുപത്രിയാണ് ഇത്. ഇവിടെ മോസ്റ്റ് മോഡേൺ ടെക്നിക്കുകൾ സമുന്നയിപ്പിച്ചുകൊണ്ടുള്ള വിവിധ സെഷനുകൾ ഇതിനു മുമ്പേയും നടന്നിട്ടുണ്ട്. ആ രീതിയിലുള്ള ആ ഒരു ഉദ്ദേശത്തിലാണ് ഇതുപോലുള്ള പ്രോഗ്രാമുകൾ ഇവിടെ നടക്കുന്നത്. പരസ്പരമുള്ള വിജ്ഞാനങ്ങൾ അങ്ങോട്ടും ഇങ്ങോട്ടും ഷെയർ ചെയ്യുകയും ന്യൂവർ അഡ്വാൻസസ് എന്തൊക്കെയാണ് എന്നുള്ള ഡിസ്കഷന് വേണ്ടിയാണ് ഇന്ന് ഈ പ്രോഗ്രാം ഇവിടെ നടത്തുന്നത്. വലിയൊരു പ്രസക്തി ഇല്ലാത്തതുകൊണ്ട് തന്നെ നിങ്ങളുടെയൊക്കെ അനുവാദത്തോടുകൂടി ഇന്നത്തെ ഈ പ്രോഗ്രാം ഇവിടെ ദൈവത്തിൻ്റെ നാമത്തിൽ ഉദ്ഘാടനം ചെയ്തതായി പ്രഖ്യാപിച്ചുകൊണ്ട് നല്ലൊരു ദിനം ആശംസിച്ചുകൊണ്ട് ഇവിടെ നിന്ന് പുതിയ വിജ്ഞാനങ്ങളുമായി നല്ല ഒരു മനസ്സോടുകൂടി ആവട്ടെ ഇന്നത്തെ ദിനം എന്ന് ആശംസിച്ചുകൊണ്ടും ഈ പരിപാടിക്ക് വേണ്ടി ഉദ്ഘാടനം ചെയ്യാൻ വേണ്ടി എന്നെ ക്ഷണിച്ച ഇതിൻ്റെ പ്രവർത്തകരോട് നന്ദി പറഞ്ഞുകൊണ്ടും ഞാൻ എൻ്റെ വാക്കുകൾ ഉപസംഹരിക്കുന്നു. നന്ദി, നമസ്കാരം, ജയ് ഹിന്ദ്.
Thank you, sir, for officially inaugurating Intensive 2025 and for your words of encouragement that truly inspire us to reach new heights. Every success story is built on the support and goodwill of many. To offer felicitations, may I now invite the distinguished guests to share their words of appreciation and encouragement. First, we invite Dr. Syed Faisal, Secretary, IMA Perinthalmanna.
Good morning, everyone. It's both my honor and privilege to stand before you today as the Secretary of IMA Perinthalmanna to facilitate this most anticipated CME on Critical Care Intensive 2025, organized by SHIFA Critical Care Department under the expert leadership of Dr. Prem Kumar. Critical care medicine is not just a specialty. It is a front line of life-saving decisions, where science meets compassion and precision meets urgency. In today's CME, we gather not only to update our knowledge, but to reaffirm our commitment to excellence in patient care. I extend my heartfelt appreciation to Dr. Prem Kumar and his team for his excellent program that promises to both intellectually enriching and clinically relevant topics. To all the participants, your presence here is a testament to your dedication to lifelong learning. Let's make the most of this opportunity by engaging actively, sharing insights, and fostering collaboration. Thank you all. Have a good day.
Thank you, sir, for your kind words and hearty congratulations for your achievement. Now I request Dr. Muhammad Ihya to present the memento to Dr. Syed Faisal C.
Good morning, all. Let me first invite our President IMA Sharafuddin, Dr. Sharafuddin, as Secretary Dr. Faisal, and other dignitaries on and off the stage. Let me congratulate Dr. Prem for conducting this auspicious clinical gathering, especially on intensive care. Almost 10-15 years before, when I was discussing with my father about a critical care department in the hospital, it was very difficult for me to introduce this type of a thing to my father, because it is very, it is very in a neonatal period in India itself, talking about intensive care, what intensive care it means and all. And when we talk about it, we try to introduce the hospital as well. Like, it is very difficult to understand, people to understand the concept of a critical care itself. But when we made sure that it is in the heart of the hospital, it's in the center of the hospital itself. And I was like very much pushing for the people who are planning about the department to make it very easy for all the people to come in very easily if the patient getting sick and can be shifted into the department. Anyway, this department has flourished in such a way that it is one of the best department in and around, leading department in and around. I especially congratulate Dr. Prem and his team for organizing this type of an event, which is very, very much best, one of his best in this area. Thank you all.
Thank you, sir, for your inspiring message. As we come to the close of this inaugural ceremony, it's time to express our gratitude. May I now invite Dr. Shahul Hamid, Clinical Administrator and Emergency Physician, to deliver the vote of thanks.
Good morning, all. വേദിയിലും സദസ്സിലുമുള്ള പ്രമുഖ വ്യക്തിത്വങ്ങളെ, സഹപ്രവർത്തകരെ, ഗുരുക്കന്മാരെ, കിംസ് അൽ ഷിഫയുടെ ക്രിട്ടിക്കൽ കെയർ നടത്തുന്ന ഇൻറ്റൻസീവ് കെയർ CMEയിലാണ് നമ്മളിന്നുള്ളത്. കിംസ് അൽഷിഫയെ കുറിച്ച് പറയുകയാണെങ്കിൽ കിംസ് അൽഷിഫയുടെ എമർജൻസി അല്ലെങ്കിൽ ഇൻറ്റൻസീവ് അല്ലെങ്കിൽ ക്രിട്ടിക്കൽ കെയർ ഡിപ്പാർട്ട്മെൻറ്റിനെ കുറിച്ച് പറയുകയാണെങ്കിൽ കഴിഞ്ഞ 10 കൊല്ലത്തിലധികമായി ഡോക്ടർ പ്രേംകുമാർ സാറിൻ്റെ നേതൃത്വത്തിൽ പ്രവർത്തിക്കുന്ന ഡിപ്പാർട്ട്മെൻറ്റാണ് ഇവിടുത്തെ ക്രിട്ടിക്കൽ കെയർ ഡിപ്പാർട്ട്മെൻറ്റ്. ഡോക്ടർ അബ്ദുള്ള ഖലീൽ അദ്ദേഹത്തിൻ്റെ പ്രസംഗത്തിൽ പറഞ്ഞതുപോലെ തന്നെ ഈ ഭാഗത്ത് ആദ്യം ഈ ക്രിട്ടിക്കൽ കെയർ മെഡിസിൻ തുടങ്ങുന്നതിൻ്റെ ആപ്രിഹെൻഷൻ ഉണ്ടായിരുന്നു. പക്ഷേ അങ്ങനെ ആപ്രിഹെൻഷൻസ് വന്നപ്പോഴും അതിനെ മുൻവിധികൾ ഏതുമില്ലാതെ ധൈര്യമായി ആ ഒരു കൺസെപ്റ്റിനെ ഉൾക്കൊണ്ട് അത് നടപ്പിലാക്കിയത് ഞങ്ങളുടെ വൈസ് ചെയർമാൻ ഉണ്ണീൻ സാറാണ്. അപ്പോൾ അദ്ദേഹത്തിൻ്റെ ഒരു വിഷനാണ് ഈ ക്രിട്ടിക്കൽ കെയർ ഡിപ്പാർട്ട്മെൻറ്റ് എന്നുള്ളത്. അത് പിന്നീട് പ്രേം സാർ അതിലെത്തി. ആദ്യ കൺസൾട്ടൻ്റായി സാറ്, പിന്നെ HOD ആയി. ഇവിടെ ഇത്രയും കാലം സാറിനെയാണ് ഈ ഡിപ്പാർട്ട്മെൻറ്റ് നയിക്കുന്നത്. ഇന്നിപ്പോൾ 5 കൺസൾട്ടൻസ് റൗണ്ട് ദ ക്ലോക്ക് ഈ ഡിപ്പാർട്ട്മെൻറ്റിലുണ്ട്. അതിന് പുറമെ നമുക്ക് ഇവിടെ FNB സ്റ്റുഡൻസും നമുക്കുണ്ട്. അപ്പോൾ ഞാൻ അർപ്പിതമായ എൻ്റെ കർമ്മത്തിലേക്ക് ഞാൻ കടക്കുകയാണ്, വോട്ട് ഓഫ് താങ്ക്സിലേക്ക് കടക്കുകയാണ്. അപ്പോൾ ആദ്യമായി ഇത്തരം ഇങ്ങനെയൊരു പരിപാടി, ഇങ്ങനത്തെ ഒരു ക്രിട്ടിക്കൽ കെയർ CME ഏറ്റവും എഫക്റ്റീവായിട്ട് ക്രിട്ടിക്കൽ കെയർ ഫിസിഷ്യൻസിനും അതേപോലെ തന്നെ അടുത്തുള്ള ഡോക്ടേഴ്സിനുമൊക്കെ തന്നെ ഈ ക്രിട്ടിക്കൽ കെയർ ഡിപ്പാർട്ട്മെൻറ്റിൻ്റെ പ്രാധാന്യം അറിഞ്ഞുകൊണ്ട് ക്രിട്ടിക്കലായിട്ടുള്ള പേഷ്യൻസിന് ക്രിട്ടിക്കലായിട്ടുള്ള കെയർ കിട്ടുന്നു, അത് കെയർ കിട്ടാനുള്ള പ്രാധാന്യം, അതും കിട്ടാനുള്ള ഏരിയാസും ഐഡൻറ്റിഫൈ ചെയ്യുന്നൊക്കെയുള്ള ഉദ്ദേശത്തോടു കൂടി തന്നെ ഡോക്ടർ പ്രേംകുമാർ സാറിൻ്റെ നേതൃത്വത്തിൽ നടക്കുന്ന, അദ്ദേഹം മുൻകൈയെടുത്ത് നടക്കുന്ന ഈ CMEക്ക് അദ്ദേഹം നേതൃത്വം നൽകിയതിന് അദ്ദേഹത്തിനുള്ള നന്ദി ഞാൻ അറിയിച്ചു കൊള്ളുന്നു. ഞങ്ങളുടെ ക്ഷണം സ്വീകരിച്ച് ഇവിടെ എത്തി ഈ പരിപാടി ഉദ്ഘാടനം ചെയ്ത റീസെൻ്റ്ലി ഇലക്റ്റഡ് ആയിട്ടുള്ള നമ്മളുടെ പുതിയ IMA പ്രസിഡൻറ്റ് ഷറഫുദ്ദീൻ സാറിന് ഉള്ള കിംസ് അൽഷിഫയുടെ നന്ദി ഞാൻ അറിയിക്കുന്നു. ഈ പരിപാടി ഇന്നിവിടെ വരികയും ഇന്ന് ഇനാഗ്രേഷൻ ചെയ്യുകയും ചീഫ് അഡ്രസ് നടത്തുകയും ചെയ്ത ഞങ്ങളുടെ മെഡിക്കൽ സൂപ്രണ്ട് ഡോക്ടർ മുഹമ്മദ് എഹിയ സാറെ ഞാൻ ഞങ്ങളുടെ നന്ദി അറിയിക്കുകയാണ്. ഈ പരിപാടിയിൽ ഫെലിസിറ്റേഷൻ നൽകിയ IMA സെക്രട്ടറി ഡോക്ടർ സയ്യിദ് ഫൈസൽ സാറിനെ ഞാൻ ഞങ്ങളുടെ എല്ലാ നന്ദിയും അറിയിക്കുന്നു. ഫെലിസിറ്റേഷനിൽ പറഞ്ഞ നമ്മളുടെ തന്നെ ചീഫ് ആർത്രോസ്കോപ്പിക് സർജനും അതേപോലെ തന്നെ ക്രെഡൻഷ്യൽ ആൻഡ് പ്രിവിലേജിംഗ് കമ്മിറ്റി ചെയർമാനും ഉണ്ണീൻ സാറിൻ്റെ മകനുമായ ഡോക്ടർ അബ്ദുള്ള ഖലീലിനെയും ഈ വേദിയിലേക്ക് നന്ദി അറിയിക്കുന്നു. പിന്നെ ഇവിടെ വന്നിട്ടുള്ള എല്ലാ സ്പീക്കേഴ്സും, രാവിലെ ഫസ്റ്റ് ടോപ്പിക്ക് നൽകിയ ഡോക്ടർ ഹാഫിസ്, അതേപോലെ തന്നെ ഡോക്ടർ ജിതേഷ് ഗംഗാധരൻ, ഡോക്ടർ അബയ്, ഡോക്ടർ പ്രേംകുമാർ, ഡോക്ടർ അനുരൂപ്, ഇനി സംസാരിക്കാനുള്ള ഡോക്ടർ രഞ്ജിത്ത് ഉണ്ണികൃഷ്ണൻ, ഡോക്ടർ ഫിയാസ്, എല്ലാവർക്കുമുള്ള നന്ദി ഞാൻ അറിയിക്കുന്നു. ഇതിന് പുറമെ ഇന്നിപ്പോൾ നമ്മളോട് എത്തിയിട്ടുള്ള കിംസ് അൽഷിഫയിൽ തന്നെ സീനിയർ ആയിട്ടുള്ള കൺസൾട്ടൻസ് ആയിട്ടുള്ള ഡോക്ടർ മാധവ് ജോഷി സാർ, ഡോക്ടർ ജാഫർ സാർ, അതേപോലെ തന്നെ നമ്മളുടെ മുൻ IMA പ്രസിഡന്റ് ഷാജി സാർ, സെക്രട്ടറി ജലീൽ സാർ, എല്ലാവരോടുമുള്ള നന്ദി ഞാൻ ഈ അവസരത്തിൽ രേഖപ്പെടുത്തുകയാണ്. പിന്നെ എല്ലാത്തിനും ഉപരി ഈ പരിപാടിയിലേക്ക് വരികയും ഞങ്ങളുടെ ക്ഷണം സ്വീകരിച്ച് ഇവിടെ എത്തുകയും ക്രിട്ടിക്കൽ ആയിട്ടുള്ള പേഷ്യൻസിനെയും അതേപോലെ തന്നെ പേഷ്യൻ്റ് കെയറിലും കൂടുതലായിട്ടുള്ള അറിവും വിജ്ഞാനവും നേടുന്നതിനായി മുന്നിട്ട് വന്ന് ഇന്ന് ഇവിടെ എത്തിയ എല്ലാവർക്കും ഞാൻ എൻ്റെ നന്ദി അറിയിക്കുന്നു. പിന്നെ ഈ നമ്മളുടെ പെരിന്തൽമണ്ണയിലെ തന്നെ ഏറ്റവും സീനിയർ ഡോക്ടറായിട്ടുള്ള ഡോക്ടർ രാംദാസ് സാർ ഇവിടെ ഉണ്ട്. സാറിനും ഇവിടെ എത്തി അൽഷിഫയുടെ ക്ഷണം സ്വീകരിച്ച് ഇവിടെ എത്തിയതിന് സാറിനോടുള്ള എല്ലാ നന്ദിയും ഞങ്ങൾ അറിയിക്കുകയാണ്. ഒറ്റ വാക്കിൽ എല്ലാവരോടും നന്ദി പറഞ്ഞുകൊണ്ട് തന്നെ ഈ ഇനാഗ്രൽ സെഷൻ സമാപിച്ചതായിട്ട് അറിയിക്കുന്നു. താങ്ക് യു.
Thank you, sir. With that, we conclude the inaugural session of Intensive 2025. Let us now look forward to an enriching series of scientific sessions and discussions throughout the day. Thank you all once again. Now, we move on to one of the most vital and evolving areas of hemodynamic management, vasopressors. Finding the right agent, timing, and titration can often make all the difference in a crashing patient. To walk us through this critical topic, we have Dr. Anirudh Balagopal, Senior Consultant Intensivist, Department of Critical Care Medicine, Aster Medicity, Kochi. He will be speaking on vasopressors in shock, evolving trends. Chairpersons, Dr. Madhav A. Joshi, HOD and Clinical Professor, Department of General Medicine, KIMS Al-Shifa, and Dr. Femida TP, Consultant Intensivist, Maulana Hospital. Please take your seats on the dais. Over to you, sir.
Good morning, everyone. At the outset, let me thank Dr. Prem Kumar, my good friend, and Team Intensive 2025 for inviting me to give a lecture on this topic. With the permission of the chairs, may I start? Thank you. So my topic is vasopressor use in shock, evolving trends. So vasopressors are agents which increase the vascular tone. They increase the stressed volume in the capacitance vessels. So basically the capacitance vessels which are becoming dilated, the stressed volume is increased and the preload to the heart is increased. Now, it is usually started in a situation where you have hypotension or diminished tissue perfusion. So how do you assess tissue perfusion clinically at the bedside? One thing is that if the patient is conscious and alert, he has warm peripheries, and there is a good urine output hourly, that is around 1 ml per kg per hour of urine output hourly without any diuretics, then it means that the cardiac output is adequate for the body's needs. So at least in a quick clinical examination, you can see that there is any evidence of diminished tissue perfusion or not. Okay. And another concept I would want the trainees in the audience to remember is that the mean arterial pressure is always a product of the heart rate, the stroke volume, and the systemic vascular resistance. So in this talk, we will be talking primarily about vasodilatory shock, where the systemic vascular resistance is low. So this will be the outline of my talk. So I'll go for it in these steps. That is when to start, where to start, what is the agent that you will strike to start, how to titrate the vasopressor, and when and how we are going to stop the vasopressor. So the first question is when to start. Previously, it was like before, in the early, around 4 or 5 years back, in the previous surviving sepsis campaign guidelines, it was said that you should give the crystalloids first, more than 30 ml per kg, and then you go for give vasopressors. Now, in the latest edition, they say that you should start off with your vasopressor early, while your crystalloid resuscitation is going on, and in a vasodilatory setting, you should start it ideally within 1 hour. Now the surviving sepsis bundle recommends that you start off with your vasopressor within the first hour of presentation. And especially in a situation where you have ARDS, renal dysfunction, cardiac dysfunction, 30 ml per kg or a large amount of fluid might not be very feasible. So, and these are two trials, the SENSOR trial and the REFRESH trial, that looked at early use of vasopressors, and they found that the outcome is better if you use early vasopressors. The time for the patient stabilization becomes easier when you start early. Traditionally, it is always thought that a central venous catheter is needed for giving vasopressors. Now, in the latest edition of the surviving sepsis campaign, they say that a peripheral line is good enough for starting off with vasopressors. You don't really need central line always. Okay. And ideally, they recommend that the peripheral line should be in or around, at least proximal to the antecubital fossa. An 18-gauge line would be a very good line to start off with the vasopressors. And they recommend that you should try to transition from the peripheral to the central within 6 hours. But nowadays, most centers use it for 12 hours, 24 hours. The peripheral line on vasopressors is good enough. But when you have higher concentrations of vasopressors, maybe it's a good idea, or you anticipate a longer duration of vasopressor usage, maybe it's a good idea to transition to a central venous catheter. So generally accepted is that you have up to 0.2 microgram per kilogram per minute you can safely give through a peripheral vascular access. And the serious extravasations that have been reported in the literature are largely from older literature, like from 60s and 70s, where we used metal cannulas like scalp veins and all to give fluids. So when the needle is inside the vein, the chance of the vein puncturing and extravasating is much more. Nowadays, with modern cannulation techniques and excellent nursing protocols, now the incidence of extravasation itself is less. So there is a daily inspection of the site and the cannula, and due nursing protocols are also followed. So the incidence of serious extravasations have come down quite a lot. So much so that in the large Clovers trial, there was only 3 extravasations when out of 500 patients being given through peripheral vasopressors through peripheral lines. And even those 3 did not have any serious clinical consequences. So it is a good practice to start off with the vasopressor early through a peripheral line rather than wait for a central line insertion always. So when we talk about vasopressors, apart from the blood vessels, they have effects across the body. Okay. Right. So you can see that it is there on the CNS. There is bronchodilation is involved, gastrointestinal function, renal function, endocrine pancreatic function, hematological function, and lipid metabolism. So our vasopressors that we give, although we are expecting results only on the vasculature, remember that they have effects across the body. And this is something which we all know, that is the order of which acts were. That is, phenylephrine is primarily an alpha receptor agent, and it causes vasoconstriction, pure alpha agent. Then we have norepinephrine, epinephrine, dopamine in decreasing order of alpha activity, and isoproterenol has maximum activity on the only activity on the beta receptors, no vasoconstrictive effects. So it's an easy way to remember the vasopressor effects of the various agents that we are giving. So next question is what to start. Nowadays there is no question at all. Noradrenaline remains first choice across whatever shock it is, be it cardiogenic, hypovolemic, obstructive, whatever it is, or you are not certain of the etiology, noradrenaline remains the first choice pressor that you start. It's a potent alpha and beta agonist, as you know, and it should be started ideally within 1 hour of diagnosis of septic shock and it decreases the time to target MAP and fluid load, fluid overload, if you are able to start it within the first hour. So the noradrenaline use started first in 1953, there is in Baylor Medical College in Houston, where they used it in around 22 patients in shock of varied etiology. Varied etiology meaning there was people with pulmonary embolism, myocardial infarction, barbiturate overdose. And of these 22 patients, almost all of them had their shock reversed with noradrenaline. So this was a seminal study which led to the widespread use of noradrenaline from that point of time. Now the Surviving Sepsis campaign recommends that it should be the first choice pressor in septic shock. The dose range is usually from 0.01 to 1 microgram per kilogram per minute. If you go beyond 1 microgram per kilogram per minute, it is usually termed refractory hypotension, and it might not be, although literature describes doses up to 5 microgram per kg per minute, above 1 mic per kg per minute, you run the risk of digital ischemia and other organ vasoconstriction. Now, what is the next agent to start in such a situation when noradrenaline is not able to achieve the pressors or you have issues with tachyarrhythmias, then what should you start off? So the next agent becomes vasopressin. Vasopressin is an endogenous peptide which binds to V1 receptors in the vascular smooth muscle. And a relative vasopressin deficiency has been described in septic shock. So it is the dose is in septic shock is 0.03 units per minute. It's a fixed dose. There is no titration involved. The Surviving Sepsis campaign recommends that you give it at 0.03 units per minute, and that is around 1.8 units per hour. And higher doses have been associated with cardiac, digital, and splanchnic ischemia. Okay. So it has a vasopressor catecholamine sparing effect. So it's best to start it early along with noradrenaline. So what is the evidence for its use? These are 2 large trials which have looked at the vasopressin use versus noradrenaline. And the first trial came out in 2008 in NEJM. It's called a VAST trial. It showed possible mortality benefit when you start it early in less severe septic shock. And there is less renal failure, and it reduces catecholamine requirements. The theoretical possibility that less renal failure also is that the efferent arteriolar constriction caused by vasopressin is more than afferent arteriolar vasoconstriction. So the intraglomerular pressure is increased. So there is less renal failure, and that has been shown in studies also. So the VANISH trial came around 8 years later, and that also showed a less need for renal replacement therapy in this cohort. And there is also less requirement for noradrenaline if you start vasopressin sufficiently early. So these have been the 2 major trials that have looked at vasopressin use in the shock setting. But there are certain undesirable effects of vasopressin which we don't want. Vasopressin's primary effect is by binding on the V1A receptor, which causes activation in vascular smooth muscles and vasoconstriction. Again, as I said, in efferent glomerular arterioles, and platelet aggregation, which is not a very desired effect for us in shock setting. Then it also acts on the V1B receptor, causing release of ACTH and prolactin, which is a doubtful situation in septic shock. Then, on the V2 receptors, it is essentially things which we don't want in the setting of shock, like antidiuresis, release of von Willebrand factor and factor 8, and vasodilatation. So these are undesired effects of vasopressin in septic shock. So how can we overcome this? Are there selective V1A receptors? So this is a selective receptor, V1A receptor, that is celipressin. It has the other mediated, like V2, V3 mediated actions of vasopressin are avoided. It decreases, it's found to decrease noradrenaline requirements. There is a reduction in fluid overload. And terlipressin also acts on the same receptor, V1A receptor agonist. The reason why it is not preferred in the shock setting is that terlipressin has a longer half-life. Its half-life is around 4 hours. And so it is not easy to titrate it in the setting of shock, but it can be used in other situations like hepatorenal syndrome and all, but it is not a good drug to titrate in the setting of shock. So it is less used in a shock setting. Celipressin being a shorter acting drug is preferred. So this is a large study which looked at celipressin use in the sepsis or septic shock setting, but unfortunately they were not able to prove a difference in mortality or ventilator or vasopressor free days. But it was well tolerated and there was less fluid overload in the patients treated with celipressin. But it is now, at present, it is recommended only in a trial setting. So what is the third drug that we can add after vasopressin? That is epinephrine. It's a powerful alpha and beta agonist. There is positive inotropy when you have myocardial dysfunction associated. Then, unfortunately, high lactate levels and tachyarrhythmias limits its administration practically. This is the reference given is for the CAT study, which was in Australia. They compared epinephrine versus norepinephrine, and but they found that the time to target map with epinephrine and noradrenaline was similar, but the limiting factors were, as I already said, high lactate levels and tachyarrhythmias. So epinephrine is preferred whenever there is an element of myocardial dysfunction also, and it's preferred as a third line when you are not getting BP control with noradrenaline or vasopressin. Now a drug which is slowly on the way out, there is, there are certain indications which you can do. There is, it is a sympathetic catecholamine, which is an endogenous hormone. It binds alpha, beta, and dopaminergic receptors. Two large studies, the SOAP, that is, first SOAP was in 2006, and the next one is in 2010. The first study showed that dopamine administration is in shock is an independent risk factor for mortality. And its administration is again limited by tachyarrhythmias and pituitary dysfunction. Now it is recommended only in select cases with bradycardia. The second study did not show that dopamine is associated with mortality, but there are a lot of tachyarrhythmias involved. So both of these studies have showed that dopamine might not be a great agent to start in shock. But there are certain indications, like when you have select cases with bradycardia, then dopamine might be an indication. And renal dose dopamine has been debunked over the past 20 years. Now, in a situation where you have a pure vasodilatory shock, phenylephrine might be an option. It has got a strong alpha-mediated action. There is no inotropic or chronotropic action for phenylephrine. So, when there is a situations of cardiac dysfunction, it's not a good drug to start. And it's an adjunct vasopressor, especially when tachycardia or tachyarrhythmias like atrial fibrillation is a concern. So, it can be started in septic, neurogenic, or perioperative settings. In neurogenic also, it's to be remembered is that in spinal shock situations, it should not be started in lesions above T6 because it can cause severe bradycardia. So only in lesions below T6 you are supposed to start phenylephrine because bradycardia is a problem. It could become a big contraindication. So bradycardia, decreased cardiac output, and splanchnic and renal vasoconstriction are limiting factors in its administration. Now we come to the new kid on the block, that is angiotensin II. It has not been available in India as such, as of now, but it might become available in the future. Renin-angiotensin-aldosterone system, it has a key role in hemodynamic stability, vascular tone, and electrolyte homeostasis. So angiotensin II, just like vasopressin, has got a catecholamine sparing action. It has got a short half-life, making it easy to titrate. And it is indicated in refractory vasodilatory shock when your noradrenaline and vasopressin are not able to keep your BP up. So just let's see how this drug works. First is that angiotensinogen, which is synthesized in the liver, is converted to angiotensin 1 by the renin, and 1 is converted to by the ACE receptor, ACE enzyme, and angiotensin 2 acts on two potential receptors, that is AT1 and AT2. AT1 is one that we all look forward to, that is the sodium reabsorption, then aldosterone secretion, vasopressin and ACTH secretion, norepinephrine secretion, and on the vascular tone. Those are all actions mediated through AT1. And AT2 has actually got an inhibitory effect on the vascular tone, and it also decreases the inflammation, cell proliferation, and it actually augments catecholamine release. So it is to both these receptors that they act. The angiotensin or angiotensin 2 acts. So this is the ATHOS 3 trial, which looked at angiotensin 2 for the treatment of vasodilatory shock. It is a large randomized control trial in over 75 ICUs across 9 countries. And the patients were already on high-dose noradrenaline. And it has proven to be an effective agent for refractory vasodilatory shock in this trial. There was an increase in mean arterial pressure. Mortality and length of stay in the ICU has not been affected. It led to faster renal replacement therapy discontinuation and better oxygenation, because as for vasopressin, it is also causing efferent glomerular arterial vasoconstriction more than afferent, so that increases the intraglomerular pressure and filtration pressure within the kidney. And it also leads to better oxygenation because it causes hypoxic pulmonary vasoconstriction, which is a protective response in the lung. So in both in the setting of ARDS and in renal failure, this drug has proven to be good. So it benefits most in patients with high renin levels. But the problem, it is going to be the cost. As of now, it is said to cost around more than 1,000 euros per day of infusion. So that would be more than a lakh per day. So let's come to a less costly alternative, that is methylene blue in vasodilator shock. Methylene blue, actually, one vial costs around only 2,500 rupees. So it's a much better alternative that we have. So it blocks nitric oxide mediated vasodilatation. It is an adjunct vasopressor in vasoplegic states, but it's not first line in shock states. Primarily, it has been described in vasoplegia following cardiopulmonary bypass. That is where the most literature for methylene blue is. And it is also described in the setting of liver transplant and in septic shock also. So let us look at the dosing and the precautions, what all needs to be done. So the initial bolus dose is around 1 to 2 mg per kg IV over 10 to 20 minutes. You can follow it up with an optional infusion. But the problem is that the pulse oximeter will not pick once you are giving methylene blue, and there is blue-green discoloration of the urine. If there is G6PD deficiency, hemolytic anemia may be precipitated. If the patient is on SSRI, serotonin syndrome might be precipitated. And if you give high doses, that is more than 6 mg per kg, methemoglobinemia is going to be a concern. Now, this was a large randomized control trial which has looked at the use of methylene blue. The authors are the same as the authors for the Andromeda shock, that is Glenn Hernandez and team, and they have looked at this early adjunctive methylene blue in septic shock. And they found that there is less time to vasopressor discontinuation, more vasopressor days, free days at day 28, and shorter ICU length of stay, and shorter hospital length of stay when they give methylene blue. They found that methylene blue as a bolus followed by an infusion was the best way to give it, rather than just as a bolus alone or an infusion alone. So they give it as in three groups. One group they give bolus alone, one group they give infusion alone, and the third group they give bolus and followed by an infusion. And that they found that the group where they gave bolus followed by infusion had the best outcomes. Now we come to another concept which is called push dose pressors. It is not at all strange to anybody working in anesthesia. From the first day, they have been doing these push dose pressures in the OT. So I'll just go through it. It is a small, it consists of small, rapidly deliquid aliquots of diluted pressors. So it is a solution for short-lived hypotension, typically following procedures or in the OT. It is associated with intubation or procedural sedation. You give somebody some midazolam or fentanyl for some procedure and the BP crashes. That is a push dose pressor is a good option. It's a common practice in the OTs, less in ERs and ICUs, but it is also coming up, especially when you are intubating a sick patient. It's a good idea to have a push dose pressor handy. And it should be a bridge to initiation. I mean, you should plan on starting off a vasopressor infusion in a short while. So what are the commonly used push dose pressors? This is the phenylephrine. This is a dilution. This is not the original dilution. These are the dilutions that are recommended when you give phenylephrine as a push dose pressor. That is 100 mics per ml. Adrenaline is 10 mics per ml. And noradrenaline is 8 mics per ml. So these dilutions are important. Standardized dilution and labeling is key. Otherwise, you will end up with fatal accidents, because these are powerful drugs, and you give them drugs without proper and standardized dilution, you will end up with problems. So the dilution is the key. As an example of the dilution, let me just tell you the dilution for noradrenaline. You are all familiar with the usual dilution of noradrenaline. We take 2 ampules of noradrenaline. Okay, that is 4 milligrams of noradrenaline. You dilute it up to 50 ml with 5% dextrose. That gives you 80 micrograms in an ml. Okay, 1 ml now contains 80 micrograms. You take 1 ml of that solution and dilute it to 10 ml, and then you get this solution. Okay, so the dilution has to be very key, because if you are not diluting it properly, or it is not diluted on a standardized manner, you will end up with large overdoses and fatal consequences. So as I said, always transfusion to an infusion as soon as possible. Confirm dilution and dosing. Again, I am saying this. And document indication, dose and response whenever you are giving it during a procedure. Education and competency assessments periodically, because remember, our nursing team will keep changing. The people drawing the drugs will keep changing. So you have to have competency assessments and testing in this case. So what are the adjunctive therapies that we can give to maintain our blood pressure? That is one of which is important. One is steroids. So this is started when you have persistently high vasopressor requirements, and which remains after adequate fluid resuscitation. Several trials have looked at, I'm just quoting the 2 major trials. Approx trial looked at hydrocortisone and fludrocortisone in septic shock, and they were found to have a mortality benefit in that trial. In the same year, adrenal trial also came, but they used hydrocortisone alone, but they were not able to show a mortality benefit, although time to the vasopressor stoppage was faster. And how long should you give? You should give it till the vasopressors are on, and once the vasopressors are off, you should slowly taper it off. So that is the steroids. Steroids are accepted as a standard now, especially the hydrocortisone dose of between 200 and 300 milligrams per day in septic shock setting. When you are already on noradrenaline and vasopressin and you have given your fluids, then you should be starting off on hydrocortisone. This is still in experimental stages, hydroxycobalamin. It is also working in a similar mechanism to methylene blue, while it scavenges nitric oxide, and additionally hydrogen sulfide is also scavenged by hydroxycobalamin. And several studies, observational studies, mind you, but they have shown a decrease in vasopressor requirements with hydroxycobalamin. But large RCTs are needed. Until then, it still remains investigational. So how to titrate the drugs? Now we have talked about what to titrate, when to start, and now how to titrate these drugs. So titration should be based on multiple parameters like clinical improvement, lactate clearance, capillary refill time, and last but not the least, mean arterial pressure. So clinical improvement, lactate clearance, and capillary refill time are all things are now which are done in fraction. I am sure people who have the recent study you might have all seen, which came out 5 days back, that is Andromeda Shock 2 trial. So there they also looked at a combination of these factors for titrating vasopressors. So let's look at the major studies which have looked at mean arterial pressure in the setting of shock. So this was the first study, that is a sepsis SPAM trial, which looked at high versus low blood pressure targets in patients with septic shock. And the target mean arterial pressure, what they looked at in the target group was between 80 and 85 millimeters of mercury. They did not find any mortality benefit with this strategy. And but there was new atrial fibrillation when you try to target a higher mean arterial pressure. And renal failure and need for renal replacement therapy was less when you targeted a high mean arterial pressure. Okay, so that was the finding of the sepsis SPAM trial. The next trial was called a 65 trial for obvious reasons, because it was across 65 ICUs in patients older than 65 with a target map of 65. So it appears safe, it said that it appears safe to target 60 to 65 millimeters of mercury even in elderly patients. And potential mortality benefit in patients with chronic hypertension was also suggested. Now this is a recent trial which came out this year in intensive care medicine. That's called the OPT-PRESS trial. There was a target map, they looked at a target map of 80 to 85 versus 65 to 70 millimeters of mercury. And the 90-day mortality was higher in the high target group. And they looked at longer duration of, and there was longer duration of organ support, and results were similar in patients with chronic hypertension. So what do you infer from these studies? What is the take-home message? So the take-home message is that the mean arterial pressure targets has to be individualized. You cannot say that one size fits all. It has to be individualized. It depends on your day-to-day assessment of the patient, on your clinical assessment. You can't say one number for all patients. So the important thing is that the Surviving Sepsis campaign also says that initial map target of 65 millimeter mercury is acceptable. That is initial. When you're starting off your resuscitation, you don't know much about the patient, then you should start off with an initial target of 65 millimeters of mercury. You can increase or decrease your target based on the other clinical parameters of perfusion. So we have to decide when and how to stop these drugs. Again, as I said, indices of perfusion are good, for example, lactate or capillary refill time, clinical improvement. All of these things are good indices to taper your vasopressors. Lactate clearance, capillary refill time, acceptable map. And last is dynamic arterial elastance, which is an upcoming thing in intensive care, which is looks at the pulse pressure variation versus the stroke volume variation as an index to predict when your vasopressor can be weaned off. So again, the question is, which one do you stop first? Do you stop noradrenaline first or vasopressin first? So there have been studies in that regard also. The first is the DOSE trial. They looked at stopping noradrenaline first versus vasopressin first. They found that when you stop vasopressin first, it is better. That is, the outcome seems to be better. But the study below, the retrospective study by Song et al., where they analyzed more than 2,000 patients, they found diametrically opposite results, where they found that noradrenaline should be stopped first and not vasopressin. So it is up to anyone to interpret these results, which one you want to stop. Personally, I would stop vasopressin first and then continue with the noradrenaline. And because noradrenaline has a very short half-life, it's around 2 to 3 minutes. It is easy to titrate. Vasopressin has a longer half-life. It's around 20 minutes. It's not that titratable. So I would go with first stopping vasopressin and titrating norad down. So to stop the vasopressors, another strategy is to shift them to oral vasopressors. So what are the oral vasopressors that are available? The first and foremost is midodrine. Midodrine is a prodrug. The active component is desglymmidodrine, which acts on alpha adrenergic agonists, and it is causing, and BP is improved. And it is also given in the situation of intradialytic hypotension. Nephrologists would be very familiar with this drug because they are giving it in intradialytic hypotension, and gastroenterologists give it in hepatorenal syndrome also. So that is one drug which you use, and intensivists are using it to get the patient off noradrenaline and out of the ICU. So that is our indication for using midodrine. The next three drugs, droxidopa, pseudoephedrine, and atomoxetine, act by increasing endogenous norepinephrine at the receptor sites. So they are all work by the same mechanism by increasing the endogenous norepinephrine. And the last is desmopressin. It doesn't qualify as a vasopressor per se, but it has been tried in weaning of noradrenaline. Now this major trial called MIDAS has been tried in weaning of vasopressors, starting midodrine and sending removing noradrenaline and sending the patients out of the ICU. But unfortunately, they could not show any decrease in time to vasopressor discontinuation, no decrease in the ICU length of stay. And vasopressor discontinuation was faster in patients on epidural analgesia. That is the only point they could find. But and the incidence of bradycardia is higher with midodrine. When you use midodrine, you should anticipate bradycardia. So now we have started the drugs, titrated the drugs, stopped the drugs, and now what are the future directions that you should be looking at in the use of pressors? So nowadays, more and more there are different shock phenotypes are described, and we should make an effort to identify the various shock phenotypes and then treat. And precision vasopressor therapy is being increasingly advocated, and personalized hemodynamic resuscitation. That is going to be the key words for the next few months. After the Andromeda Shock 2 trial, which came out, as I said, 5 days back, they were all been talking about personalized hemodynamic resuscitation for each patient. And in the future, you can look for AI-based infusion protocols which will titrate the drugs according to the patient's condition. So to summarize, I would say it's a life-saving intervention in the shock. You start early and titrate to effect. Focusing only on the BP might be too simplistic. And individualized and closely monitored therapy is the need of the hour. Thank you for a patient hearing. Any questions? I'll be glad.
Thank you, sir, for that well-structured and highly practical talk. You simplified a complex topic and gave us real clarity on tailoring vasopressor therapy to each patient's physiology. A great takeaway for all of us. Now we request the chairpersons to share their thoughts on the session.
Thank you, sir. Sir, nowadays, vitamin C, that after the Marek paper, it was being used left, right, and center, and we were also using it. High dose vitamin C, we were using it in all our septic shock patients. But now with the large randomized controls, the large four or five randomized controls which have come, they have not been very positive, and so we have stopped using it. We were using it on a regular basis, we were using it, but after the last couple of years, several RCTs came which showed that vitamin C is not going to be a great benefit, so we have stopped using it right now.
What is your experience regarding hydroxychloroquine?
I have not used it, sir. I have not used it. It's just that I found that in the literature search, I found it, but I have not used it. I plan to try it in some cases. I have used methylene blue. I have found it to be useful. But again, things change because methylene blue, the problem is once you give methylene blue, the pulse oximeter reading becomes unreliable. That becomes a concern. The urine starts turning greenish blue. The patient relatives comes and starts asking questions. All these things, practical things start happening. Thank you. Actually, there is, because if you feel, as I said, it is individualized. You can take your decision call based on the patient's condition also. Early start of vasopressin is actually recommended. You don't need to wait for a high dose of noradrenaline to build up before you start off with your vasopressin. You feel that there is atrial fibrillation, and atrial fibrillation itself is contributing to your decreased cardiac output. And if you are giving an agent which is increasing the rate further, you don't want that. So you can add vasopressin early enough. I don't know whether about starting it as a first line agent. I have not used it like that, but early start of vasopressin, definitely yes. I have also used it.
At what level of noradrenaline dose would you suggest to start vasopressin?
Regularly in our unit, what we recommend is that when we cross 10 ml per hour of noradrenaline, that translates to 1 ml per hour is around 0.02 microgram per kg per minute. 10 ml per hour is 0.2 microgram per kg per minute. And when we cross 10 ml, when we reach 10 ml, we start off with vasopressin. Thank you. Yeah. Yes. The same day, same thing. Oh, we give midodrine. Midodrine, right, left, and center. We are giving midodrine nowadays. We start with that 5 mg 8 hourly. We are going up to 10 mg 8 hourly because many patients, the usual tricky thing is that patient will be on 2 ml of noradrenaline. We will not be able to wean that 2 ml off. Whatever we try, that 2 ml will be there. So we will, after rounds, we will wean off the patient, stop the vasopressor and go back. By the time I come back, the nurse will have restarted the noradrenaline. So in that case, we usually start off with the midodrine. We start at 5 mg 8 hourly, we go up to 10 mg 8 hourly. I think gastroenterologists go up to 15 mg 8 hourly also sometimes. And we have found it to be useful. Unlike the study, we have found it to be useful in decreasing the time to, faster shift out from the ICU. And also we have found it to be very useful in when your patient is about to get dialyzed and you are anticipating that there could be hypotension. It is best to give midodrine before the dialysis. At least 1 to 2 hours before dialysis, if you give midodrine, the intradialytic hypotension is prevented to an extent. Mefentramin, we used to use largely in the OT. I'm an anesthetist by this training. So that when we started training in anesthesia, we were using mefentramin right, left, and center. But nowadays it seems to be less available. There is a question of availability. Ephedrine also we were using, but ephedrine now it seems there is a more chance of tachyarrhythmia. So we are not using it that much. So if you have to have a push dose pressor, the safest would be noradrenaline. Or what we do nowadays, practical situation is we start, even in the patient's normal BP, we start the noradrenaline infusion, keep it at 1 or 2 ml, and when we see the BP dropping, we hike it quickly. That is what we do practically, rather than loading a push dose pressor. I am very doubtful about the dilutions, because untrained, if the people who are not properly trained, they dilute, you could end up with disaster. So I am not very confident of that. I would much rather stick with an infusion.
Thank you, sir.
Thank you. Dobutamin, yeah. Dobutamin is primarily an ionodilator. So it's basically vasodilatation is the primary action. So if you have a situation where you have a myocardial dysfunction along with in septic shock, noradrenaline plus dobutamin would be a combination. But dobutamin is not a vasopressor alone per se. But you can use it along with noradrenaline if you have a situation where there is myocardial dysfunction. Thank you. Thank you. Thank you, sir.
Thank you, sir. Now I request Dr. S. Ramdas to kindly present the memento to our speaker, Dr. Anurup Balagopal. I also request Dr. Jafar CP, Senior Consultant and Clinical Professor from Department of General Medicine, KIMS Al-Shifa, to present the mementos to our chairpersons. Thank you, sir. Next, we move on to a topic that can turn any calm ward into a high adrenaline scene within seconds, anaphylaxis. It's that one emergency where speed, confidence, and presence of mind make all the difference. To take us through this crucial topic, we have Dr. Ranjit Unikrishnan, HOD and Senior Consultant Intensivist, Department of Critical Care Medicine, Apollo Adlex Hospital, Angamali. He'll be speaking on anaphylaxis, a nightmare for any clinician. I warmly welcome our chairpersons, Dr. Vijay Krishnan J, Consultant Critical Care Medicine, EMS Memorial Cooperative Hospital, and Dr. Ans Ashley, Physician General Medicine, KIMS Al-Shifa, to kindly take their seats on the dais. Over to you, sir.
morning or good afternoon, everybody. At the outset, let me thank our friend Prem and for giving me this opportunity. It's always a pleasure to be here with him. So, on the topic, anaphylaxis is an acute, life-threatening situation due to a sudden release or degranulation of the mast cells with all the cytokines surging into the systemic circulation, producing significant pathophysiological effects in the vascular tree as well as end organs, which could be potentially fatal. So it's a classically IG mediated, even though there are other mechanisms. It's predominantly IG mediated. So basically, it means it's an allergic response. So basically, it's a very bad killer allergy that is in gist about anaphylaxis. It has a lifetime prevalence of around 2%, but we are seeing there's an increasing trend, maybe because of the changes in the lifestyles that we are having, with the mortality with the current critical care of around more than 1%. Now, if you, we're all very familiar with allergy as such, because that's very common, unlike the prevalence of anaphylaxis, general allergies, pruritus, angioedema, with hives. We all personally have experienced that. So this is a very common, response. It's an immunological response that is produced, which is very common. And in general practice also, we do come across that. So how is anaphylaxis different? So the whole point would be to differentiate for an emergency physician or any clinician to differentiate general allergic response from a major anaphylactic response. So that's one of the key things. What could trigger anaphylaxis or severe allergy? Anything which can produce allergy if it's a different in a context or higher exposure, or there are cofactors. We don't exactly know why. Sometimes it's just an allergic response, and sometimes it's a massive anaphylactic response, because the dose effect thing is not really outlined. We are not exactly sure. But generally, the things that can cause allergy can actually cause anaphylaxis also. Insect stings, that, bees, wasps, and even sometimes some ant bites. These are all quite a reason for anaphylaxis, especially if your exposure is, environment is outside. The next thing is food. The common things are nuts, obviously, peanuts, or the other nuts like cashew or even hazelnuts. These nuts have proteins which can induce allergy. Even hen, egg, milk is the other possibilities. Medications, most studied and most common are the antibiotics, especially the beta-lactams, penicillins, and other ones. The other one is natural rubber or latex. These are the common things, even though, as they say, as the dermatologists say, anything under the sun, including the sun, can cause allergy. So it's interesting to note that even human semen can produce allergy in women, and maybe a condom can also produce allergy and anaphylaxis. So that's quite a scary situation. So what happens is, why is IG-specific pathways, how is it initiated? So as you can see here, there is IG-specific exposure to antigen. It sensitizes the IgE, and IgE actually sits on the mast cells like this. And when you have second exposure, there is cross-linking of the allergen with the IgEs that are on the mast cells. And that cross-linking is what actually can produce release. It degranulates and releases the mast cells or basophils. So basically, this is the way all the cells work with degranulation, engulfing, phagocytosis. So basically, IG-specific pathway works with mast cells or basophils degranulating with the allergic exposure. So this is one fundamental difference when you have an anaphylactoid versus anaphylactic reactions, because anaphylactic is IgE-specific. Anaphylactoid, the word is actually no more recommended by large bodies because just to reduce confusion. So in anaphylactoid reactions, IgE mechanism may not be there, which means that if there's a direct exposure of certain chemicals to certain receptors on the mast cells that can degranulate upfront. So there need not be an exposure like you see in the Redman syndrome in vancomycin, maybe cold-induced, exercise-induced. So all these cold and exercise, they can be confounders, or they can actually accentuate your anaphylaxis also, and they may produce certain anaphylaxis-like reactions also. So the other one is immunological but not IgE mediated, whereas IgG mediated, not a well understood phenomena. Especially this is supposed to be seen more with when you're using infliximabs and all those mAbs, which are not exactly IgE mediated, and these may produce upfront allergic reactions, which can look like anaphylaxis. In treatments could be very similar. So from a practical point of view, because the mediators are same, your effector drugs could be similar. So differentiation is more of a theoretical thing. But you have to understand that for first exposure can produce anaphylaxis-like responses also. So now let's consider certain situations, clinical situations. Like one is like this young man who has, a urticarial rash on his face and body, and he presents with some respiratory distress to the physician. So there is some bronchospasm on examination, but he's otherwise fine. So his vitals are otherwise okay. Even doesn't have much of tachycardia, his BP is fine. So is this anaphylaxis? That's a question. So as per the criteria that are laid by the World Association of Allergy and other bodies, this is anaphylaxis because as per this definition, anybody with a skin allergy with bronchospasm or respiratory involvement or hypotension or hemodynamic instability, hemodynamic deviation should be treated as having anaphylaxis. So as you know, 90% of situations we expect to the presentation of anaphylaxis preceded by skin response. So it's a very common thing. It's one of the fundamental things to see for a skin response. Now consider this situation where a boy with a history of known allergy to food. So he has allergy to shrimps and shellfishes. So he presents after going to a restaurant. So actually he knows he has allergy, so he's not supposed to take. So he did not take any of those, but some restaurants can use pans which are common for cooking. So after that he found out, and then he had that crampy pain. So he visited a hospital. He was a bit dizzy, but his examination was largely within normal limits. So on asking, he said that he had certain itching which is no more there. So currently his skin doesn't look like having anything significant, but he is having abdominal pain with vomiting, and is known to have an allergy. So probably there's an exposure. So is this anaphylaxis? So as per this criteria too, if you have any of these two, and there is a probable exposure to an allergen, like if you have skin, respiratory, hemodynamic, or gastrointestinal, it has to be taken as anaphylaxis. So this fits into a criteria of anaphylaxis. Now consider this situation where this lady is a very common situation, who has been on ceftriaxone for quite a few days in the IP, suddenly develops tachycardia and distress, and she's known to have hypotension on examination. So is this anaphylaxis? So is it possible to have anaphylaxis after many days of exposure? Of course, yeah, because allergy, the chances never goes away with number of exposures. It is still there, and it can happen during the late exposures also. So any allergy, you cannot rule it out just because there has been a previous exposure and there has been no allergic response. So that will not rule it out. So according to this criteria, reduced BP or hypotension, like 30% decrease or less than 90 systolic blood pressure after a probable exposure to an allergen should be taken as anaphylaxis. Now, why are we bothered about all these criteria, and why are we pushing? Because the treatment is simple, straight, upfront, and there's no doubt on that, and these people should get IM adrenaline. There's no doubt. Why? Because we don't know the course of anaphylaxis. Some of them could be quite, they will settle down. Many or quite few may not. So a late administration of adrenaline or not recognizing that this could be an anaphylaxis could be fatal, because late adrenaline administration is a known risk factor for fatal anaphylaxis. So if in doubt, that's why the criteria has been made simple, and you can actually, if in doubt, you have to use IM adrenaline, that is onto the thighs. So generally the course of illness, it peaks pretty fast, maybe in minutes. So it resolves by around 30 minutes to 1 hour, it peaks, and it resolves by a couple of hours. So this is classical course. It may not be the situation all this time, because of the degranulation. Once it happens, it cascades like any other cascades that we know of in inflammation or coagulation. It has exponential, kind of a curve which it produces. So it should be usually massive and very fast. There are certain other presentations, like one is called the biphasic presentation, where you have a primary, like a uniphasic is like you have massive onslaught. That is a common thing that we expect. The second is a biphasic presentation, where you have one anaphylaxis happening, and there is a kind of lucid interval thing, because so this improvement with medications, and then the patient has another episode without re-exposure that is known, maybe in hospital. So this thing, like, it is not a very common phenomena. It's a feared phenomena, because suppose you discharge such a person, you may have been in trouble. But it's not a very common phenomenon. Late, literature has pointed out it's around 5%, so it doesn't prevent, just sending a person to home. Just you need to warn them. Generally, it happens in a couple of hours, maybe in 6 to 12 hours, 4, 5, 6 hours. But it is reported as late as 72 hours. So you have to give a warning for that. So you don't have to keep a person for that. So the other one is a protracted anaphylaxis, which means the anaphylaxis doesn't happen like this as an onslaught. It comes there, it stays there, and it goes off slow. So again, this patient may require a longer, ICU stay or hospital stay. The other one is a delayed anaphylaxis, because anaphylaxis to the allergen exposure is not classical, so you're not able to really differentiate. Classically, this is seen when somebody gets out of the bed and and say that I'm breathless, and that looks like an anaphylaxis. So there are certain things, and like food allergy is one of the things that has been implicated in delayed anaphylaxis. As you'd be aware, there's the syndrome called alpha-gal syndrome. So alpha-gal syndrome is where a person has allergy to red meat, beef, pork, or whatever, or sometimes other animal products, because it has alpha-galactose. So there is an exposure to a tick bite that actually is said to be triggering this, because a tick saliva has alpha-galactose-like thing, so it can actually, multiple tick bites over time can actually, sensitize the body to alpha-galactose, and since it can cross-react to this alpha-galactose in the red meat. So this usually is generally seen as a late thing. After dinner, generally people get up in the middle of the night saying that I'm breathless, or I have hives or hitches, itchy skin, pruritus. So again, this is not very commonly diagnosed here, because the diagnosis requires certain testing. Generally reported more in the Western Hemisphere. I think it should be there in our area also. Look, certain situations that you have to be bothered about. Patient already is non-allergy, or patient is on antihistamine. They may not present classically with hives or skin. The skin manifestation may not be manifest. So you could miss that it could be an anaphylactic response. The second situation is a perioperative anaphylaxis. It's a very scary situation, because the patient is under your care, and patient is come for something else, and suddenly you have to see that the patient is just going down, hitting a rock bottom, and there is a possibility of mortality. So this is a discussion in itself, but a couple of points of interest would be, one, the patient is draped up fully, the skin may not be seen, so there could not be the classical thing that you see. The temperature may be different, so the patient may not complain of anything, because they are under sedation anesthesia. And generally seen by sudden changes in the hemodynamics, or the EtCO2 suddenly dropping down because the cardiac output is coming down. So early recognition, the common triggers could be anything like a neuromuscular blocker or drugs that have been used or a latex or whatever. So it has some mortality and significant mortality, and the recognition is warranted here. The other situation is if the patients are non-asthmatics, so the presentation could look like an asthma exacerbation which will not get an IM adrenaline. If you don't recognize it as an anaphylaxis, you may miss that possibility. So these situations, and it is a well-known risk factor for fatal asthma. Difficult asthmatics have higher mortality when they have anaphylaxis. And in the first episode may not be recognized because you don't know what's exactly happening. You may not recognize the syndromes that is happening. So these are odd situations which have to be thought about. Now coming to the lab markers, as you all know, there are no real-time markers because this is so fast, you have to act so fast, so you don't have to really look into the labs. But are there roles? There are roles for lab markers like tryptase, as you know, has a role because in the later part of the story, if when the patient is being evaluated, you may have to see that high tryptase could actually indicate that this was anaphylaxis. And fall in tryptase maybe after 2 days would confirm that. And the fall is not happening, it may actually indicate something like a mast cell disorder or things like that. So these are all not for the emergency ICU situation, but if you don't take a tryptase sample, you may not really understand that. I don't do serum tryptase. This is what is the general recommendation, but not related to the emergent care or acute care. The other thing is plasma histamine. Again, it has to be taken at least in 3-4 hours, or at least till before 6 hours, and it has to be sent in a frozen sample. So there is logistic issues, but second part of the story, it may help. Plasma histamine is also, obviously is a primary marker or the mediator of this whole thing, but it has a very short half-life. It is actually metabolized pretty fast, so you may not really get it in the blood, but 24 hours urine histamine, these are all possible ways of looking at it from a laboratory point of view, but as we all know, it's a very clinical thing and will not help in our practice. Now again, these things like, can we find a cause? Should we try to find a cause? Should we try to then avoid it? Of course it has to be done because that is one way to prevent fatal, or you don't know which reaction is going to be fatal. So this is an important thing. So it's a different discussion, maybe not in our perspective, our purview to actually discuss the allergy, immunological thing of it. So there are skin testings, intradermal or other prick testing that have been done. There are issues with, medications. There are no standard, testings that are easily available. For food allergy also, there is difficulty in doing the entire gamut of testing. Currently, ELISA, allergen-specific ELISA for a set of non-allergen is also one way of looking at it. But this has to be done by an immunologist or an allergy specialist. The differentials for is actually in two forms. One, suppose somebody just has a massive cardiorespiratory attack, or somebody is not collapsing. This could be anything of that sort can be a differential for anaphylaxis from that point of view. So other things like thromboidosis is one situation. Thromboidosis is a condition where certain fish, especially like these mackerels and all, they have high histidine. So when histidine, they have some spoilage. Bacterial contamination can actually produce histamine out of histidine because histidine is converted to histamine. So if you actually ingest them even after cooking does not change that. So significant amount of histamine is absorbed, can produce something which looks like a anaphylaxis, but exactly it's not IgE related. It is similar presentation. So the management is to actually stop the ongoing trigger if there is one, and then get to resuscitation as early as possible. Management we have already discussed. The central pillar for management is IM adrenaline, anything like 0.3 to 0.5 milligram, or according to the weight. If it's a refractory situation with this, you go on to infusion. As as Andrew was mentioning, push pressors doses is also possible because in a moribund situation, anything to get into the circulation is needing, it needs a pump because circulation, it's a peri-arrest. You have to push small doses with all the precautions that Andrew was already mentioned. So the idea is to get an A, B, C, D, E of anaphylaxis starts with adrenaline and then airway. So when you're getting ready for the airway, you have to give adrenaline. So adrenaline, that's only one take-home message, the whole thing. Non-subcutaneous, this is a very erratic absorption. Not IV in general because it can produce dramatic changes in the hemodynamics, because I've seen a person getting IV adrenaline because people are not very sure what is happening, and then it was like, the horror of a life. You could see all kind of arrhythmias happening in the next minutes, and the patient was kind of, she could not kind of understand what was having an impending doom like that. So once you see that, IV adrenaline is a dangerous, obviously it's a very dangerous drug. So obviously Andrew has in detail discussed alpha-1 as a beta-1, beta-2. So enough reasons why adrenaline is the drug of choice for such a significant shocky, leaky disease. Intubation, airway, the best chance, one single shot, that is the rule. You have to get the best person. If the time allows, you have to get the best person to do it, because laryngeal edema and upper airway edema are people who, the more you have seen, you know how dangerous it can be. Accessories to intubation, it's called a triple setup. Plan A, Plan B, and Plan C should be there. Front of neck access has to be attempted very fast, because whenever a person has, angioedema or skin hives, always if there's a voice change, there's a hoarseness, if the uvula is edematous, be prepared, or anyway be prepared for a difficult airway, and try to get people, if it's possible, your best hands anywhere in the hospital. The other adjuvants, oxygen, IV fluids, because all these situations, there is either, relative hypovolemia, there's a vasodilation, splanchnic. There is significant leakage here. The capillaries are leaking, and there's a lot of shift to the interstitium. So to maintain effective circulation, you may have to use significantly large amount of crystalloids. Generally colloids are not recommended. Salbutamol can actually add on to the bronchodilation that adrenaline is not able to give. Antihistamines, H1, diphenhydramine, Avil, or if it's an IV, or even type 2 H2 receptor agonist like ranitidine. It has some additional H1 effects, and it can reduce pruritus and all, along with diphenhydramine. H2 agonist alone has no role here. Steroids, if this is a significantly long one, it's a protracted one, they could help in reducing recurrence. These adjuvants are actually just adjuvants, so they actually are given after adrenaline as per the indication. So what is refractory anaphylaxis, which one more important for our ICU critical care or emergency thing? There are multiple definitions, but in general, if there is no poor response to second shot of IM adrenaline, that is every third or 5 minutes when you give IM adrenaline, are you not getting adequate response, then probably consider this as refractory and go on for, these are the pathophysiology. There could be a massive leak. Why some of them go for refractory is not exactly known, because it could be because of the drugs that are already being used, like catecholamine resistance, beta blockade, all these, confounders. So basically, if a patient doesn't respond to a second dose of IM adrenaline, it's better to think of IV adrenaline, start as an infusion, and maybe use small push doses. As Andrew was mentioning, peripheral administration is fine because you don't get a time to put central line at the situation. It can be done any time later, and it requires very close monitoring. And obviously, when it's a refractory anaphylaxis, the patient is going to get into they won't get discharged from the emergency most probably. They may all get into the ICU and may require a significant ICU stay. Fluid we already discussed. Glucagon is other possible mediator or hormone that can be used here, because if there is a significant catecholamine resistance, because if escalating your beta catecholamine use, like noradrenaline or adrenaline. These are other, it doesn't require the catecholamine receptors, so it bypasses them. It is a second receptor activator, and it actually increases CA-AMP through adenyl cyclase mechanism. So the dose is like 1 to 5 mg that is given as a bolus, slow bolus, and this infusion. I personally use this quite a long back, but what I remember is, one, it's difficult to get. Second, it has a very short shelf life. So if you don't get an anaphylaxis in a short period, you will be in trouble. So it's costly also. So that is one problem with glucagon that I remember. So that can be used for any shocky situation where this beta blocker or other drugs have been used. Methylene blue in detail Andrew has discussed, so obviously it is a different mechanism. It inhibits NO synthetase. So basically, again, these drugs, when adrenaline doesn't work, using higher dose adrenaline and noradrenaline may not be the answer. You look for the other possible receptors. That's common knowledge. Now, what about ECMOs or extracorporeal support? So in vasodilatory shocks and severe inflammatory responses, in general, it may not be as simple and as effective as you using it in cardiogenic shocks, but definitely it can stabilize the situation. It can give you some lead time so that all the drug starts working. So I don't have a personal experience using this in kind of an anaphylaxis, but the recent recommendations all have added extracorporeal as one possibility. Suppose somebody is like crashing down to stabilize, why not? So these are the key messages of treating refractory anaphylaxis. I think we've gone through that. So there is an entity called fatal anaphylaxis also. Half of them are due to because of medications. In general, the time of allergen exposure to the peak effect is very fast in this subset. They may not get the time to come to a resuscitation point or an emergency. So basically, these are like an avalanche of release of things, and the patient could die. So this is an entity that you have to remember of. These are the risk factors: concomitant asthma or existing allergy in a younger person, or if the person is elder, already having diseases, so that they can't really withstand this onslaught. The other thing is poor response to adrenaline is one risk factor. You have to immediately recognize that this person may not survive. There is a high chance that he may require very high-end care and monitoring. And delay in administering adrenaline is a known risk factor from the iatrogenic point of view, because you are either not sure or you're reluctant. So that is one avoidable thing. So again, discharging a general situation of anaphylaxis is like not more than a day. You just need to tell them that they could have a biphasic or a longer attack. You have to be careful. So when you discharge, probably you tell that this is a major event, so it can actually, you can have another attack in 1 or 2 days, come back to us. And adrenaline is the name of the drug that can save your life. And you have to get to the nearest emergency if you feel that you are going to have an allergic response. And you can have further episodes of this, and you have to be prepared. So this is an action plan, kind of emergency action plan that has been given in writing to them, and it has been told to the patient as well as the patient's caregiver. Emergency use of adrenaline has to be taught, and that has been taught to the immediate caregiver also. They have to be actually advised to go to an allergy specialist or a physician who is doing an allergy, because that is important for us legally also, and for the patient's better outcomes also. So one issue that we have is non-availability of EpiPen. So there's a standard, the pre-filled, the auto-injectors. So we still don't have an auto-injector as such available. And we don't have very good pre-filled syringes, so we only could be giving them adrenaline. That's what I have seen in practice. But I think there are significant government-level initiations. That is what I understand. Even in this parliament session, I think there was a discussion on this. So I expect that something would come up. That's all. Thank you.
Thank you, sir, for that crisp and impactful session. practical points perfectly explained for one of the toughest emergencies. I now invite our chairperson to share any remarks or addition.
Thank you, ladies, sir, for the vast and insightful experience. Thank you for the expertise. And now we have come across this important topic, and we got to know about what are things to be done. It's just a refreshment for all the conditions that have conducted to know here. And yeah, it's and it's of course the first thing that we have to do, and apart from that we have to give the support, all the supporting measures with area management. That is the main issue of the discussion. So, any questions from the audience?
No, adrenaline has no contraindications in general because it's a life-saving. See, obviously, it can produce its own, if there's somebody has a heart failure, it can overshoot. But IM, I think there's no contraindication for sure because it's a life-saving drug. So I don't think it's like asking like there's a contraindication for ECMO in shock. So obviously, or ventilation when somebody is respiratory failure. No? So obviously the benefits would outweigh the risk in almost all situations. So no contraindications. You have to just use it. That's the whole point. So I don't know the juniors who may not be kind of using it, especially in in a small clinic or somewhere. IM adrenaline has to be used. IM adrenaline is it absorbs 0.3 mg. It doesn't produce a lot of it's a slow absorption. It has to be used. It has to be used. In doubt, use.
Thank you, sir. May I now request Dr. Prem Kumar PS to present the memento to Dr. Ranjit Unikrishnan and Dr. Sayyid Nawaz Afzal to present the mementos to our chairpersons as a token of gratitude. Now, we move to the last session today. The topic that always keeps us on our toes in the ICU, the bleeding patient. Managing these cases demands calm decisions, teamwork, and rapid action. This session will be delivered by Dr. Fiaz Hamzat, Consultant, Department of Critical Care Medicine, KIMS, Al-Shifa. He will be speaking on the topic, the bleeding patient, damage control, and critical action. I warmly welcome our chairpersons, Dr. Nadeem MP, Consultant and In Charge, Department of Emergency Medicine, EMS Memorial Cooperative Hospital, and Dr. Robin Sebastian, General and Laparoscopy Surgeon, KIMS Al-Shifa, to kindly join us. Over to you, sir.
Good afternoon, everyone. First of all, I would like to thank everyone who is present here, taking time out of your busy schedule. I'm excited to present before you the topic, bleeding patient, damage control, and critical action. In the fast-paced world of trauma care, where every second counts, it's important to know the basic principles of resuscitation and how to stabilize a bleeding patient before he crashes. The objectives of this study: first of all, we will understand the pathophysiology, grasp the complex mechanisms of severe bleeding, and understand the lethal triad cascade, expertise the DCR principles, define damage control resuscitation, and implement its evidence-based protocols in clinical practice. Also, have an idea about the critical decision making. Introduction to the bleeding patient. The clinical reality is that the severe traumatic hemorrhage is the leading preventable cause of death. The lethal triad of coagulopathy, acidosis, and hypothermia exacerbates the bleeding and leads to irreversible shock and if not interrupted early. There is also immunological dysfunction associated with these patients, that is upregulation of the innate immunity and downregulation of the adaptive immunity, which creates a hostile microenvironment for hemostasis. Time is crucial here, it is very critical, and early intervention and rapid hemorrhage control is key to breaking the lethal triad cycle and preventing the irreversible shock and organ failure. Going into the 2025 ATLS guidelines update, there was the traditional primary survey has been a ABCDE approach, and the 2025 ATLS update, they have added an X before the ABCDE. The X stands for exsanguination and external hemorrhage, where we have to do everything possible to stop the bleeding or the hemorrhage control in the patient even before they have a management. The new primary priority is to immediately control the life-threatening bleeding. You can apply, this can start even in the pre-hospital care when the patient is brought from the accident site, where you can apply high tourniquets in the proximal extremity immediately, use combat gauzes or hemostatic agents, and also direct pressure on the sites where it is accessible, the wound is accessible. Why X comes first? Because exsanguination happens within 1 to 3 minutes of trauma. So we have to start to break the lethal triad of all the complications of a trauma patient. You have to control the bleeding immediately. The tourniquets are actually effective for up to 2 hours, and hemostatic agents reduces the bleeding by about 90%. It saves lives before even the patient is arrived in the hospital. So this is the primary survey 2025 update. Going into the pathophysiology of trauma, the trauma pathophysiology is basically the deadly triad, the death triad. It includes hypothermia, acidosis, and coagulopathy. It is a self-perpetuating cycle, and breaking this lethal cycle is paramount in the management of trauma care. Hypothermia worsens the enzyme activity, acidosis and coagulopathy through decreased metabolism and oxygen delivery, where acidosis impairs clotting factors, causes vasoconstriction, worsening hypothermia and perpetuating coagulopathy, where coagulopathy increased blood loss exacerbates hypoperfusion, leading to both hypothermia and acidosis in a continuous escalating cycle. So breaking this triad is important in the management of trauma. Going into the trauma-induced coagulopathy, trauma itself causes coagulopathy by 3 major mechanisms. First thing is that there is a rapid consumption of large number of clotting factors because of widespread tissue damage. Then the next step, when the patient arrives in the hospital, we resuscitate the patient with a lot of fluids and blood. So the effective coagulation factors concentration is reduced because of the dilution effect. And thirdly, there is an endothelial glycocalyx shedding, which releases anticoagulants into circulation. So these 3 mechanisms causes trauma-induced coagulopathy, which is prevalent in almost 25% of the cases that gets admitted with major trauma. So this can be detected with hemostatic point of care methods like TEG and ROTAM. There is also a component called resuscitation-induced coagulopathy, where there is dilution after massive infusions. The effective concentration of the coagulation factor is reduced, and that itself causes coagulopathy. And also hypothermia can lead to and cold blood products, and when the core temperature of the patient decreases, impairing the enzyme kinetics and platelet function, which can affect the coagulation cascade. This is also compounded by if patient has been taking alcohol or is on antiplatelet drugs or anticoagulant drugs. This can actually compound the effect of coagulopathy. Going into the diagnostic approach of coagulopathy, there should be a clinical suspicion when the patient has an altered mental status, or he's having tachycardia, or is having hypoperfusion. This all should make us think that this patient is having some sort of coagulopathy. There is severe hemorrhage despite all ongoing interventions. Patient is bleeding profusely from multiple sites, and there is poor response to initial blood or fluid resuscitation. Laboratory parameters, when the base deficit is more than 6 milliequivalent per liter, lactate is more than 2 millimole per liter, PT-APTT is more than 1.5 times the normal, and temperature is less than 35 degrees Celsius, and pH is less than 7.2. The usual testing for coagulation is that we are doing in the hospitals are this PT, prothrombin and APTT. The problem with PT and APTT is that this patient's core body temperature could be 35 degrees Celsius or 34 degrees Celsius, and we are taking the patient's blood and going into and giving the blood to the laboratory where that test is being done in room temperature. So the effect of hypothermia in coagulopathy of the patient's body status is actually missed when we do PT APTT. That's why advanced hemostatic monitoring has been introduced. It's a point of care testing. It's a rapid assessment of clot formation kinetics and stability, provides real-time data within minutes to guide resuscitation decisions. It's a goal-directed protocol, identifies specific coagulation defects like platelet dysfunction, fibrinogen deficit, hyperfibrinolysis for targeted correction. It is superior to standard tests like PT and APTT. So we have discussed the pathophysiology of trauma and also how to detect the coagulopathy. The laboratory and clinical parameters have been discussed. Now we are going into how to resuscitate a patient in 4 critical settings. When a trauma happens, the patient's management actually starts from the point where the trauma happens. That is the pre-hospital care. The patient has to have a very rapid hemorrhage control, a tourniquets and hemostatic gauzes, and rapid transfer to the trauma team in the emergency department has to be done as early as possible. So there should be a good communication between the emergency medical service team and the trauma team in the ER. So that is the pre-hospital care. When the patient reaches the emergency department, we have to continue the hemorrhage control. As much as possible, we have to continue the hemorrhage control and also initiate permissive hypotension, which we will discuss in detail later. And also prevent lethal triad. And if necessary, the patient has to be prepared for surgery. In the operating room, the traditional management of a trauma patient in the operating room used to be like definitive repair of whatever the trauma happened. But the new paradigm shift in this in the DCR protocol is that there is rapid the patient is taken into the OR and there is a rapid bleeding control. There is no definitive repair. The patient has to be packed, shunted, or embolized, or whatever the means to rapidly control the bleeding. Then shift the patient to the ICU where the patient's acidosis, hypothermia, and coagulopathy is corrected. Then after stabilizing the patient, you take the patient back to the OR in 6 to 48 hours where the definitive repair can be done. This is found to have a better outcome for the patient in trauma care. So that is one difference that is being compared to the traditional management of trauma. So in the operating room, you take the patient and do whatever possible to rapidly control the bleeding, then take the patient to the ICU, then where he's stabilized and taken back to the OR in 6 to 48 hours. This is the most important part of this topic. When a patient arrives in the casualty or in the OT, he's in hypotension, he's profusely bleeding, the most common thing which we all do is rush the fluid. You take a pressure bag, you rush fluid, like 1 liter, 2 liter, 3 liter. Maximum you try to give. But the problem with this aggressive crystalloid resuscitation is that it is found to be having increased mortality because the patient's coagulation factors is already consumed because of the trauma. I already told the trauma-induced coagulopathy. Those things have already happened, and we are going to try to give a lot of fluids. What happens is that the rest of the coagulation factors that is in the patient's blood gets diluted. It actually causes a dilutional coagulopathy. That is the primary reason we have to avoid crystalloid resuscitation. And outcome in the studies that have shown that aggressive versus permissive resuscitation, the mortality, ARDS, multi-organ failure, and the transfusion need has been found to be less with DCR, there is a permissive resuscitation compared to the traditional aggressive resuscitation. So this is completely different from the usual other forms of shock like septic shock or other forms of shock. In hemorrhagic shock, especially in trauma, you try to avoid or limit the use of crystalloids. It is also associated with pulmonary complications like over-resuscitation causes pulmonary edema, ARDS, prolonged mechanical ventilation, and increased ICU stay. The other complications of aggressive fluid resuscitation include cardiac complications. Even with an increased preload, the patient can have increased RAP, right atrial pressure, which can lead to arrhythmias and worsen the hypotension. There can be GI and abdominal issues like bowel edema, GI dysfunction. Patient can go into abdominal compartment syndrome. There is also immunological dysfunction associated with aggressive fluid resuscitation. So DCR saves lives by addressing the hemorrhage early and systematically, breaking the lethal triad cycle through rapid control, balance resuscitation and physiological restoration rather than early definitive repair. That is the modern trauma resuscitation evidence. Now going into the topic proper, it is the damage control in trauma. It is a very integrated approach. There are 3 core phases, 6 key domains, and it's a continuous cycle, and the mortality reduction is found to be 40 to 50%. So first phase is the damage control resuscitation, which can start, like I said, can start in the pre-hospital care or in the emergency department. So there is, we have to do everything possible to hemorrhage control. There is a early hemorrhage control is paramount in damage control resuscitation. You have to start active rewarming, avoid hypothermia, then use, minimize the use of crystalloids to less than 1 to 1.5 liters, then go into balanced transfusion ratio, that is 1:1:1 with PRBCs, FFPs, and platelets. So this can be directed with the TEG and ROTAM based therapy. Instead of going on and giving all blood products in an equal ratio, you can use a TEG and ROTAM and guide it as a, you can use it as a guide for a balanced resuscitation. Next up is you take the patient and stabilize after initial stabilization from the ER. If the patient needs an hemorrhage control from the with a surgery, you go for a damage control surgery, which what you have to do is minimize the operation time and rapid bleeding control using embolization or packing or shunts. And hemorrhage control is the priority, and temporary closure and planned return to OR, like I've said, after 6 to 48 hours. Then there is an intensive care phase where we try to optimize the patient, like the active rewarming, hypothermia correction, acidosis correction, coagulopathy correction. Then you prepare the patient for a definitive repair in 1 to 2 days. The systematic DCR approach, you have to arrest coagulopathy early, recognize the lethal triad components, and implement some simultaneous interventions for hypothermia, acidosis, and coagulopathy. Restore physiological stability, use balanced blood products, active warming, permissive hypotension to prevent cascade progression and organ failure. Improve overall outcomes, like early implementation reduces mortality, organ dysfunction, and improve long-term recovery compared to traditional resuscitation. Now going into the indications of damage control resuscitation, although this can be implemented in almost all cases, there are specific indications for DCR, like clinical presentation where there is a multi-regional exsanguination with competing visceral injuries requiring prioritization and staged management approach. Injury pattern like multiple penetrating or high-energy blunt torso trauma with major vascular involvement. And physiological criteria include grade 3 for hemorrhagic shock, non-responsive to initial fluid therapy. Physiological indicators for DCR protocol activation: hemorrhagic shock grade 3 for base deficit of more than -6, lactate level more than 2, coagulation status PT ability more than 1.5 times the normal, core temperature less than 35 degrees Celsius, and the patient is fluid not responding to initial fluid bolus therapy. Going into balanced resuscitation, the core principle is to balance. There is, you have to balance that the patient need to have adequate organ perfusion also while you have to minimize the bleeding. The patient is actually actively bleeding, and there is, you have to also maintain adequate tissue perfusion. The balanced resuscitation core principle is to maintain the adequate perfusion while also reducing the bleeding which is actually actively happening. So that is hypotensive resuscitation protocol, which is also known as control resuscitation or permissive hypotension. You don't have to target a normal BP for these patients. We can target a very lower BP like 80 to 90 millimeter of mercury till hemorrhage control is achieved, except in TBI patients, traumatic brain injury, when a higher blood pressure is targeted around 110 millimeter mercury. Initial fluid strategy, you give a 1 liter of crystalloid fluids to establish an initial resuscitation. By that time, you try to arrange blood and start blood component therapy as early as possible. Limit the total crystalloid use to less than 1.5 liter to prevent dilutional coagulopathy. Then there is a perfusion and coagulopathy balance. Target adequate vital organ perfusion while limiting the fluid administration enough to prevent factor dilution. You can reassess this with the TEG and ROTAM based and also clinical response. This is the 2017 World Journal of Surgery flowchart for the management of major trauma, where when the patient arrives in the ER with a major trauma, you give 1 to 2 liter of clear fluid as a resuscitation. Then the patient could be non-responder with no source control, pH of less than 7.3, base deficit of more than -5, and temperature less than 35 degrees Celsius. You can initiate the massive blood transfusion protocol and take the patient to theater for source control. If the patient is non-responder with no source control, pH of more than 7.3, base deficit of less than -5 and temperature more than 35 degrees Celsius. Or if it's a responder with source control, pH less than 7.3, base deficit of more than -5 and temperature less than 35 degrees Celsius. You try and start with PRBCs. Having a good response, you can take and take investigation as necessary, and surgical and conservative management can be tried. But if it's a poor responder, we can go for the massive transfusion protocol and take the patient to OR. If it's a good response with initial fluid resuscitation, and the patient is having source control, pH is more than 7.3, base deficit of less than -5, and temperature of more than 35 degrees Celsius, you can investigate as necessary with surgical or conservative management with judicial clear fluid use. The same journal has presented the systolic blood pressure goals during resuscitation. In case of penetrating trauma, the target SBP is 50 to 70 millimeter mercury with palpable radial pulse endpoint, prevents secondary bleeding. Blunt trauma, where the target SBP is 80 to 90 millimeter mercury, higher targets for blunt mechanisms and reduced internal bleeding risk. Traumatic brain injury, where we have a target of a higher target with 100 to 110 millimeter mercury or a mean arterial pressure of more than 70 millimeter mercury. Higher BP is for neuroprotection to maintain a adequate cerebral perfusion pressure. The new emerging strategy in DCR is the use of whole blood. Most of the tertiary centers don't keep whole blood. We have PRBCs, platelets, FFPs, but we don't have whole blood. In the peripheries, there is more use of whole blood, but we don't have. But the emerging strategy in the DCR is to use whole blood transfusion. It is actually a lower titer whole blood is approved by American Association of Blood Bank and advocated by THOR and TCCC protocols. The advantages is that there is a single donor advantage, like reduces the immune response compared with multiple component donors, reduce the volume administration, and it minimizes the TACO risk. Multiple studies confirm cold stored whole blood is safe without increased mismatch incompatibility risk. It's also decreased mortality associated with whole blood usage compared to blood component therapy. And the practical advantages is that it simplifies the logistics, reduces the thawing time, and improves the availability. Future direction is to use pre-hospital availability, which expands globally. Evolution of DCR towards rapid, effective resuscitation. Adjunctive medications, you have to use a in particular cases, we have to use a pharmacological support to enhance hemostasis and prevent coagulation cascade failure. The most important drug is tranexamic acid, which should be used within 3 hours of injury. It should be used as 2 gram, 1 gram over 10 minutes as a slow IV, and then the next 1 gram is given as an infusion over the next 8 hours. It reduces the mortality by inhibiting the fibrinolysis and stabilizing the clot formation. Calcium supplementation, 1 gram IV after initial blood unit transfusion. Repeat after every 4 units to prevent hypocalcemia. Induce coagulopathy during massive transfusion. Coagulation support with recombinant factor 7A, prothrombin complex concentrate, and fibrinogen cryoprecipitate as directed by Tagore rotomonitoring. Going into the hemorrhage control in emergency department, you can use direct pressure and gauzes like manual compression with gauze or bandages, combat gauzes or hemostatic agents, which can prevent bleeding, severe bleeding. Elevation and splinting of the affected limb to prevent rebleeding and to maintain until surgical hemostasis is achieved. In tourniquets and binder application, you can use it in proximal extremity tourniquets for limb hemorrhage, pelvic binders, junctional tourniquets for groin and axilla, temporary chest wall clips for penetrating injury. There can also be adjunctive procedures that can be done in the ER, but we'll need surgical support also in that situations, like chest tube insertion, ED thoracotomy in profound shock with trauma, resuscitative hysterotomy for obstetric hemorrhage, and Ribova for non-compressible torso hemorrhage. In a specific population, resuscitation has to be tailored. Like in pediatrics, the maximum fluid use is 20 ml per kg, adjusted hemoglobin targets and age-appropriate vessel access. Geriatrics, 20 ml per kg fluid restriction, hemoglobin target usually of more than 9 gram per deciliter, and mean arterial pressure target of more than 70 millimeter mercury. Severe burns, you can use Parkland formula. CKD, avoid high chloride fluids, which can worsen the acidosis. And severe LV failure, we can use vasopressors simultaneously for adequate perfusion without fluid overload. Damage control resuscitation, the key outcomes. The implementation of DCR protocols have significantly improved the survival in severely bleeding trauma patients by addressing physiological derangements early and preventing the lethal triad cascade. So comparative outcomes in DCR compared to traditional resuscitation, we have been found to have a mortality benefit, organ failure, ARDS, multi-organ failure, and survival rate all has a better outcome in DCR protocol compared to standard resuscitation. Integrating the damage control surgery, like I've mentioned before, you have to minimize the OR time through rapid bleeding control through using package, packing, shunting, or embolization. Temporary closure, pack abdomen and place temporary closure, allowing ICU-based physiologic stabilization and coagulopathy correction before return to the OR. And you reopen the patient after initial stabilization in 6 to 48 hours for the definitive repair. Practical DCR implementation pathway, recognition and activation. You have to have a high index of suspicion in severe hemorrhage. You have to identify the lethal triad and activate the massive transfusion protocol. You do everything possible for hemorrhage control, which starts from the pre-hospital care, in the casualty or in the ER, and also in the OT. Initiate permissive hypotension. You don't have to target a very high BP in a patient that is already bleeding. Radial artery just palpably is more than enough. And begin permissive hypotensive resuscitation. Blood product, minimize the use of crystalloids to less than 1.5 liter, and use a balanced 1:1:1 transfusion and warm all fluids, and draw labs, and you can guide this resuscitation using TEG or ROTAM. ICU stabilization to correct hypothermia, manage acidosis with permissive hypotension, and prepare for OR return in 6 to 48 hours. Challenges and clinical consideration. Even with the permissive hypotension, you have to monitor for over-resuscitation. Special consideration for TBI patients where the target is slightly higher compared to a normal patient. And coordinate the emergency medical service team with the hospital trauma team. Balance aggressive resuscitation with minimizing the crystalloid exposure. And future directions, we can use pre-hospital whole blood and early tranexamic acid administration. Key takeaways. What are the things we have to do in DCR protocol? Implement the protocol immediately. Use 1:1:1 ratios of blood. Maintain permissive hypotension. You have to prevent hypothermia actively. Early hemorrhage control before hospital arrival whenever possible. Permissive hypotension 80 to 90 millimeter mercury until hemorrhage control, except in TBA when a higher target is maintained. Rapid transition to blood products. Minimize the use of crystalloids to less than 1.5 liter. Active rewarming of all fluids and patients. And point of care use of ROTAM instead of a traditional PT APDT INR tests. Key takeaways: never overresuscitate with crystalloids, avoid delayed hemorrhage control, avoid hypothermia, avoid aggressive fluid resuscitation, avoid use conventional coagulation parameters, and avoid scene time delays and transport. Thank you for your attention.
Thank you, sir, for that strong and informative session, simple, direct, and full of take-home points. Now over to our chairpersons for any remarks or addition.
Involves with hypertensive resuscitation, hemostatic resuscitation, and minimizing the
There's no studies based on that, but it is actually a very, you can get the report very fast. You know, that the scene time, the delays in the reporting and the initiation of the products can be done quicker. But there's no evidence per se that it has the tegenrotam has a better mortality benefit. Yeah, that is the. No, there is the tegenrotam monitoring is preferred over the traditional test of BTCT or BTAPT-INR. Pressors, it's a dilemma. That's actually because we have to maintain the adequate perfusion. It is if the patient comes into a ER with hemorrhagic shock, better to start with fluid and blood products, and maintain the BP of around 90 to 80 to 90 of systolic blood pressure. There is no particular role in vasopressors because the cause of the shock is hypovolemia. But like I said, in case of a severe heart failure patient, or if there's a mixed shock, if you feel like that, you can actually start vasopressors. Otherwise, you try to resuscitate with fluids and blood products.
Thank you, sir. Now I request Dr. Dasan Karat, Senior Pediatrician, to present the memento to Dr. Fiaz Hamzat and Dr. Sujit S. Nair to present the mementos to our chairpersons. Thank you, sir. That brings us to the end of Intensive 2025. A big thank you to all our speakers for their amazing sessions, our chairpersons for their support, and to everyone here for making this first edition so special. It's been a great day of learning and sharing. Hope you all enjoyed it as much as we did. A special word of appreciation to our organizing committee and management for their constant support in making this event a success. Thank you all once again for being part of Intensive 2025. Wishing everyone a pleasant day ahead. Please join us for the lunch arranged in the dining hall. Thank you and have a wonderful day.